Now let's start with the next topic, and that is the red blood cells or hematology in general. When I'm talking about the red blood cells or in general hemat, first I want to ask all of you that I hope you remember what were the needles that we were using. These are the two needles that have been asked recently in the exam. So these are the bone marrow aspirate needles. Bone marrow aspirate needles include Salha's and Klima's needle. How am I going to identify them? For Salha's needle, we have something known as a side screw. So you can very well see a side screw over here. So Salha's is a side screw, and when I'm talking about a Klima needle, it has a longitudinal screw. So I can see a longitudinal screw over here. So this is the Salha's needle, this is the Klima needle. Salha has a side screw, Klima has a longitudinal screw. These were the questions that came in the recent exam, the bone marrow aspirate. The next question that they ask you, what is the site that you have for bone marrow aspirate as well as a bone marrow biopsy? And the site is going to be posterior superior iliac spine, PSIS. PSIS is the spine, is the site for it. Now, this is how a bone marrow biopsy is going to look like. This is a bone marrow biopsy which tells me that it has what all? It has ye jo dot 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 hai, these are all the cells, and then it has these white spaces. These spaces are nothing but fat. These white spaces are fat. So in general, I get to know that the bone marrow is going to have cells as well as fat. And please remember, when we are talking about an adult, the ratio is equal, 1:1. Cells is to fat is exactly the same, 50-50%. 50% cells, 50% fat. That is a question again in the previous year questions. Now moving forward, this was all about the bone marrow. Let me show you what a peripheral smear also looks like. What are the three things in a peripheral smear? These ones are known as red blood cells. All these are referred to as the white blood cells, and finally these tiny little dots are referred to as the platelets. So red blood cell, white blood cell and platelets are the three things. But what stain has been used? So in general what we use is the Romanowsky family of stains. Why am I calling it a family? Because a family will have many members under it. It can be the Giemsa stain, that is one of the very famous stains that we have. Next is the Leishman stain. Next is going to be the Wright and the Jenner and the Field. थोड़े से ज़्यादा नाम हैं. There are little more names that you have, but one time learn it and then the entire hematology is sorted. So we have Giemsa, Leishman, Wright, Jenner and Field. All of these come under a Romanowsky family. Mostly you will see Giemsa and Leishman being used. In 99% of the cases, Giemsa and Leishman are going to be used. But one place in microbiology where Field stain will be used, please remember F for F. Field stain is a very important stain for Plasmodium falciparum. F for F, field stain for falciparum. So, ये हो गया peripheral smear का all basics. Now, I'll actually start with the chapter that I'm dealing with, and that is the red blood cells. So, first you need to know how are the red blood cells forming? What is erythropoiesis? How do we get to a proper red blood cell? So, the first story starts from blast. You can see till the time the word blast will be coming, those are the things that are going to be present in the bone marrow, and those are the things that are going to have a nucleus. So the bone marrow will be the site and the nucleus is going to be there, and this is what you're going to do. You're going to make a line over here. This line will tell you that whatever has blast is going to be in the bone marrow. All of those will have the nucleus. This means as soon as I start using the word site and site, this has now come into the peripheral blood. It is not in the bone marrow and it is not going to have the nucleus. As simple as that. So till the time blast hai, bone marrow mein hai and nucleus hai. When blast is not there, it is in the peripheral blood and nucleus is not there. Please note the order now. The first one is the pro. Pro matlab the pro of the series, na? The first one of the series, and the first hemoglobin appears here. The first hemoglobin is going to appear over here, but it is only seen on which microscopy? It is only seen on electron microscopy. These are the questions that you get for the pro member. Question number 1, the first hemoglobin appears here and it is seen on electron microscopy. Then you have, after the pro, you have normoblast, and kya hai? Early, intermediate and late. Do you think anyone's going to give you these three names and say put them in the order? Even a non-medical can do early, intermediate, late. So this is not how the question will come. These are also known as BPO. That is how the question will come. So this is B for basophilic normoblast. Then we have the polychromatophilic normoblast. And finally, we have the orthochromic normoblast. So basophilic normoblast, polychromatophilic normoblast, and orthochromic normoblast. This is what they'll ask you, that please put the BPO in the correct order. That you should be able to do. And now if I said that the first hemoglobin is seen on electron microscope in a pronormoblast, you'll say, ma'am, we are not that rich. We don't have electron microscope. We have a light microscope. So hemoglobin on light microscope will be seen in which situation, in which condition? So remember, ये जो intermediate वाला है or the polychromatophil one, that will start showing you hemoglobin on a light microscope. So if the examiner just asks simple question, hemoglobin formation starts where? So the pro is going to show you the hemoglobin. It starts from the very first day. But over there, it is only seen on electron microscope. So you should be able to answer this also, that where do you see it on light microscope? That is intermediate or polychromatophilic normoblast. Now coming to blast story ho gaya. So bone marrow is done, nucleus is also done. Now the story comes into the blood. Nucleus is out, bone marrow se bhi out. It's in the blood. So what is the cell that we have? This is a reticulocyte. So please remember, this is how a reticulo. Firstly, do you know why do I call it a reticulocyte? Because reticulo reminds me of reticulum. It is a reticulum of RNA. That is what is the first question that they ask you. So basically, if I say you want to stay in a reticulocyte, you'll say, ma'am, indirectly you're wanting to say that I have to stay in RNA. Na? So RNA के लिए क्या stain होता है? RNA के लिए या reticulocyte staining के लिए we have something known as a supravital staining. We have something known as a supravital staining, and please note that supravital staining has some examples, and the best one is new methylene blue. There's also something called brilliant cressyl blue, but new methylene blue is actually said to be the best supravital stain that we have. And can you all see new methylene blue na to kuch blue color hoga? Can you all appreciate these blue color things that are going to be there, hai na? So now please note that over here we are going to ask you what is the normal retic count. The normal retic count is 0.5 to 2%. Pehle to please ye rat lo. The normal retic count is 0.5 to 2%. Examiner doesn't give you the normal count. But now if they ask you a formula, what is corrected retic count? CRC, you have to mug up the formula. It is retic count multiplied by hemoglobin upon hemoglobin. Hemoglobin of the patient divided by hemoglobin of a normal person. And mathematically, let's take it to be 15. Let's say hemoglobin of a normal person is 15. So repeating, corrected retic count is retic count multiplied by hemoglobin upon hemoglobin. So if I give you an example that someone's reticulocyte count is coming out to be 6%, and hemoglobin of the person is very low, severe anemia, 5 grams, they will ask you what is the corrected retic count. That is how the question will come. So corrected retic count is reticulocyte matlab 6% multiplied by hemoglobin of the patient. Patient ka hemoglobin kya hai? That is 5 divided by hemoglobin of a normal person. Let me consider it as 15. So what is the corrected retic count now? 2%. So see, mathematics to everyone can do as long as you know the formula. Corrected retic count is retic count into hemoglobin upon hemoglobin, and normal hamesha 15 le lena. Your maths will become easy because I know medicos ka maths is anyway very bad. So that is also sorted. Now, once this is done, this means this entire flowchart is done. You've made a reticulocyte. Now you have made a proper red blood cell. So you are ready for all the RBC indices. You have to tell me the normal values of MCV, MCH, MCHC, RDW, PCV or hematocrit, whatever you want to call it. These all normal values you have to tell me. So firstly, what does MCV tell you? MCV tells you the size of the red blood cell, and it is equal to 80 to 100 femtoliters. FL stands for femtoliters. So if someone asks you what is the normal size, it is 80 to 100 femtoliters. Okay, for MCH, I can see it's telling you a measurement of hemoglobin, and MCHC is telling you a measurement of hemoglobin concentration. है ना? So please note that for them, how will I learn? You start from 27, you end at 37. Means, and you cut it in between. 27 to 32 picogram is MCH, and 33 se start karo to 37 gram per deciliter is MCHC. How simple na? You start from 27, end at 37, put a break in between. So 27 to 32 and 33 to 37. That is the difference that you have. Simple. Now we come to RDW. RDW is what? RDW is the full form of RDW is red cell distribution width. RDW stands for red cell distribution width, and this is telling me a variation in size. This is telling me a variation in the size. So please note carefully. Alag individual size is asked, you will mark MCV. If they ask you variation in size, that is RDW, and that is equal to 11.5 to 14.5%. 11.5 to 14.5%. So this is what you know. So if I say what is your height, I'm just asking you your height. So your height, if I'm asking you, I'm asking you your MCV. But if I ask you that you are a group of 10 people, I want to know the variation in your height. Someone is 5 feet, someone is 5.5, someone is 6 feet. So if I'm wanting to know the variation in your height, I'm basically wanting to ask you about the RDW. Simple to everyone. Now the last one. What is PCV? PCV is said to be packed cell volume. Packed cell volume is nothing but hematocrit. And remember, hematocrit is somewhere around a 45%. Male, female में different होता है. Don't learn all those values, just learn 45%. So what is hematocrit? If this is your blood sample, whatever red blood cell have packed, whatever red blood cells have packed at the bottom, that is hematocrit. So you will say out of the entire blood, 45% is the red blood cell. That is the matlab of hematocrit. So how do you measure it? Please remember there are two tubes that you have to know. One is known as the Wintrob's tube. Wintrobe tube, as you can see, can you all notice? Initially you filled blood till here. Guys, please note, we took the blood sample and we filled it in this entire container, in this entire tube. After some time, all the red blood cells have gone. See, from here, as you saw, from here we could notice if the blood was still here, it has fallen from this level to this level. So, pehle to you will say whatever has come at the bottom is the packed cell volume, whatever is packed at the bottom. And from here it fell till here, that is the erythrocyte sedimentation rate. Erythrocyte sedimentation, how much has it sedimented? So can I say Wintrobe's tube can tell me the PCV and it can tell me the ESR. It can tell me how much is packed at the bottom. It can also tell me how much has sedimented, how much of it has gone down, and that is the use of the Wintrobe's tube. Whereas in Wintrobe tube, देखो tube छोटा सा tube Wintrobe tube. Whereas a लंबा सा tube, not tube pipette, lengthy one. Look at this long one over here. So long name will come up over here. Westergren pipette. Westergren pipette, and Westergren pipette only and only measures ESR. It only shows you how much is falling. It is not going to tell you PCV. So first know the identification. Chota wala tube, chota wala naam. So small little tube over here, you have Wintrobe, small name. Wintrobe is small name. It tells you small name but doing a lot of things. Big things come in small packages. Hai na? So small name, small tube, but telling me two things. It's telling me ESR also, PCV also. This Westergren is a very lengthy name. Westergren, very long name. So very long tube, but telling me only one thing. It is only telling me ESR. I hope everyone's okay with this, and all your RBC indices are also sorted, because now we can start off with the first set of anemias, and that is the microcytic hypochromic anemias. I hope you all remember the mnemonic Sita or Sheetal, whatever you want to learn. Microcytic hypochromic anemias include number 1, sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease, and lead poisoning. And let me tell you, lead poisoning is nothing but a type of sideroblastic anemia only. So somewhere I am going all the way back. So I prefer to know the mnemonic Sita, because I know lead poisoning is nothing but sideroblastic. But some people want to do alag, so your wish. So repeating, it is sideroblastic, iron deficiency, thalassemia, anemia of chronic disease, and lead poisoning. These are microcytic hypochromic. Of course, the most common deficiency that we have in our country is iron. So iron deficiency anemia is what I'll start with. Anemia, so they're not interested in only. They are actually more interested in the iron metabolism. So tell me, what is the site of iron absorption? Iron gets absorbed from the very famous duodenum, which you have studied many times. So what are you going to do? You're going to make a duodenal cell over here so that life becomes a little easy. So here you have a duodenal cell. Okay? Now in this duodenal cell, what are you going to see? This is your food item, and the food that you consume, guys, do you know that has iron in Fe3+ form? But duodenum says no, 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 I cannot absorb iron in Fe3 plus form, मुझे तो Fe2 plus चाहिए, then only I will allow you to absorb it. So first you have to change Fe3 plus to 2 plus by cytochrome B reductase. Cytochrome B reductase से you will change it to 2 plus, and now I will say fine, I allow you. Now this Fe2 plus is gonna come inside the duodenal cell. You know why? You'll say, why ma'am, I'm not understanding. Why have you made these strict rules ke 2 plus ही absorb होगा? I have not made these rules. There is one person who is acting very difficult, and that person over here is the DMT1. What is DMT? Divalent metal transporter. Look at his name. Divalent metal transporter. He is saying I will only allow things with 2 valencies to pass. Divalent. So magnesium 2 valencies it can pass. Manganese 2 valencies it can pass. Copper 2 valencies it can pass. Similarly for iron it said 2 valencies hoga to it can pass. 3 valency hoga it cannot pass. That is the reason I converted the food into Fe2 plus, because the DMT1 over here, that was creating a problem. So now has the iron come in? Very good. But I don't want to keep it in duodenum. Na? Duodenum is not where I want to keep the iron. What is your ultimate aim? Ultimate aim is take the iron to the bone marrow. Wahan par all hemoglobin and all is being formed. So iron is needed in the bone marrow. Wahan leke jao. How should I take it? First, bring the iron in the body. Don't keep it in the duodenum. Bring it in the body. Dekho, what did I say? Iron ko port karo in the body. Means there is something over here known as ferro for iron, port because it is a port, a channel, and in because I'm bringing it inside the body. What did I say? Ferro because it's iron, port, and in because I'm getting it inside the body, and here you have iron inside the body. So you'll say very good, you converted it to 2 plus, you have got it inside, up 2 plus ka koi role nahi hai. Now you're gonna bring it back into the 3 plus. So what a nice trick we did. Only for getting it inside, I converted it to 2 plus. Now it's back to 3 plus. This time, how will I convert it to 3 plus? With the help of hephaestin and ceruloplasmin. With the help of hephaestin and ceruloplasmin, I am going to convert it into Fe3 plus. And you'll say, now you are ready. Take it to the bone marrow and let it make hemoglobin. But guys, no one is allowed to travel solo. Solo travels are not allowed in the body. No one, iron cannot roam around on his own and reach the bone marrow. You will combine it with something, and that is known as transferrin. So a lot of people ask me, what is the transportation form of iron? Iron is going to get transported with transferrin, and the name is only telling me, na, trans for transport, ferrin for iron. So it's for the transport of iron, that is transferrin. Please remember how much of transferrin is saturated. Normal transferrin saturation is 33%. Normal transferrin saturation is going to be 33%. Coming to the next, what is the storage form of iron? The storage form of iron is ferritin. Bank account, I call it bank account of iron. Bank account of iron is ferritin. ठीक है. But what is this? Master regulator of iron, and that is something जो अभी हमने पढ़ा ही नहीं, and that is hepcidin. Remember, the master regulator of iron is hepcidin. So question number 1. What is the source of hepcidin? You'll say, ma'am, what is this joke that you're cracking? Hepcidin ka source, of course, liver, hepatic. It has to be the liver. What a joke. Easy question. But next question is, what is the function of hepcidin? So if I look at hepcidin, hepcidin is a very, I call it hijacker. Hijacker, if someone hijacks your house, God forbid, but if someone hijacks your house, what is he going to do? Will he let anyone enter your house, or will he let you leave the house? Entry, exit, सब कुछ बंद ना. Hijack मतलब everything closed. So tell me, will it allow you to bring iron inside the body? Will it allow you to absorb iron? No, na. So it inhibits iron absorption. Entry हो गया बंद. So you will say, ma'am, if someone is not letting me bring any money into my house, I will have to take money out of my bank account. Simple. If you don't earn money from somewhere, I will have to use my bank account. Na? Hijacker will never let you use your bank account also. Who is your bank account? Your bank account is ferritin. Hijacker says, I'm going to hijack everything. So this is going to inhibit ferritin also. It will inhibit the release of iron from the bank account also. So please remember that hijacker means neither will iron enter into your system, nor will iron be taken out from the bank account. Full hijack, full stop. So one thing though you will ask me, that so much of iron absorption you told me, hijacker goes and sits where? Does it hijack here? Does it hijack here? Does it hijack here or here? That is important, na? So please remember, the hijacker whom I'm labeling as red hijacks ferroportin. Who is going to be the hijacker? Hepcidin. Hepcidin says that fine, yahan tak to iron aa jayega, but after that I will not let you get it inside the body. I have stopped the entry, not allowed to get it inside the body. So hepcidin inhibits ferroportin. Simple with everyone. So this is sorted about your iron metabolism. Now they will ask you about, of course, the iron deficiency anemia. So when I'm dealing with iron deficiency anemia, they love to ask you the different blood findings of iron deficiency anemia. So thoda sa put your common sense into it. Anemia hai to hemoglobin will be less. It is a microcytic hypochromic anemia, hai na? We were doing microcytic hypochromic anemia. Microcytic means MCV is less. Hypochromic means MCH and MCHC are also less. So now we have got everything that is less, basically everything is less, but one thing is problematic, and that is RDW. I am saying that the RDW is going to be elevated. The RDW is going to be elevated. What is RDW? RDW is variation in size. RDW is the variation in size. So you'll say, why ma'am? You were saying chota red blood cells hai. All of them are chota. Why are you saying variation in size? Put your logic into it. It's iron deficiency. Iron will not remain deficient for all the days. Some days you will have good food, some days you will not. Some days you will have iron supplement, some days you will not. So iron levels will keep fluctuating. Food related hai na, diet related hai. Iron levels will keep fluctuating. So some days you will have small RBC, some days you will have production of big RBC, some days you will have production of small, big. Variation hota rahega. So the variation will show. RDW is going to be elevated. So I have learned in iron deficiency anemia, everything is deficient, everything is low, but RDW is high. Similarly, when I look at the peripheral smear, what all am I seeing? Firstly, you'll say, of course, ma'am, you are seeing microcytic hypochromic anemia. They are all chota cells, microcytic hypochromic anemia. But other than that, you are seeing that some cells are very, very chota. Some cells are a little normal, then very, very chota, then a little normal. So are you seeing a variation in size? Yes, you know what is that is what I told you for RDW also, na, that variation in size hoga because it is a diet problem. Variation in size is known as anisocytosis. Variation in size is referred to as anisocytosis. Okay. Next you have, I can see a very famous cell over here, and that is the pencil cell. You'll say, oh, pencil cell, matlab there is a variation in shape also. The shape is also changing. Variation in shape is known as poikilocytosis. So can I say iron deficiency anemia shows you variation in size also known as anisocytosis. Variation in shape, it has a P. So variation in shape matlab poikilocytosis, both are noticed. And which shape variation have you noticed over here? I could see the presence of pencil cells. I could see this pencil cell beautifully forming in a lot of places. Hai na? Fine. So ultimately I've understood everything is less, but RDW is more. But what about the iron profile? Please note, iron deficiency anemia hai, so iron will obviously be low. If iron is low, no one is going to get transported. Transferrin saturation will also be low. There is not going to be anyone in the bank account. So ferritin is also going to be low. But what is going to be the level of total iron binding capacity? Repeating once again, firstly know the full form. What is TIBC? It is total iron binding capacity. Basically, it's a hunger. Tell me one thing. If I don't give you food for 2 days, I am saying I'm not giving you any iron. You have no transferrin saturation. You have no iron in your reserves. You have no food at all. What will your hunger become? Your total iron binding capacity is going to go very high. You will be very, very hungry. Hai na? So simple. Everything is less, but TIBC is going to be more. Everything is going to be less, but TIBC is more. So in one sentence, if you want to revise iron deficiency anemia, everything is less, but RDW is more. Everything is less, but TIBC is more. That is iron deficiency anemia. And finally, what are you going to do if by chance they ask you which is the most definitive or specific diagnosis? Jo no one does. Let me tell you, no one does this. But remember, you will do a bone marrow aspirate biopsy and you will put Pearl stain. Pearl stain is for what? Pearl stain is for iron. And will you get zero iron in the bone marrow because iron deficiency hai? But do you think for something which every third person of our country has iron deficiency anemia? Iron deficiency anemia is nothing but chota sa iron ka problem. For that, do you want to do such a big test called bone marrow studies? No, you don't want to do. No one does this. But when it comes to exam, sometimes we have to do it. So basically, the examiner asks you that what is the most definitive, most specific test kya hai? Do a bone marrow aspirate biopsy, put a pearl stain. When you won't see anything, you will say that it is a case of iron deficiency anemia. What is the next one that you have to study, guys? The cousin brother of iron deficiency anemia. I'm still in my Sita mnemonic. So after this, we are going to next study anemia of chronic disease. Please let me tell you, when I'm dealing with anemia of chronic disease, the chronic disease could be something like a rheumatoid arthritis, just as an example. So whenever there is a chronic disease, it increases something called interleukins, interleukin 6. Interleukin 6 is going to go and act on the liver. And which is that master regulator that comes from the liver? The hijacker is going to come out. So they ask you this question, which anemia is associated with the elevation of hepcidin? So that anemia is anemia of chronic disease. So tell me something. Hijacker, will it let iron come into your system? No. Will it let you use your iron from your bank account? No. Hijack ho gaya. No entry, no exit. So tell me one thing. When I'm dealing with the case of anemia of chronic disease, like I said, pehle to just revise with me, what did you study for iron deficiency anemia? You'll say, ma'am, iron deficiency mein to everything was low. And only the hunger was very, very high. Hai na? Everyone remembers? But in anemia of chronic disease, tell me, when interleukin 6 and hepcidin are functioning, hepcidin matlab hijacker, will it let you enter, absorb any iron? Nahi, iron will be low. When iron is not there, no one is going to get transported with transferrin. That is also low. Next, will it let you use any iron from your bank account? No. Imagine, my bank account has millions of money, but I'm not allowed to use it only. What a waste. So your bank account is going to have a lot of money, but hijacker will not let you use it. So bank account is very, very rich. Can you see that difference between iron deficiency anemia and anemia of chronic disease? And iron deficiency anemia is that real, genuinely poor person who is saying, I don't have any iron, I don't have any transferrin, and genuinely poor, matlab bank account maybe there is no money, there is no ferritin. But anemia of chronic disease is pseudo beggar, the beggars that you see on the road nowadays. They are showing to you that they don't have any iron, they don't have any money, but when you open their bank account, they are richer than all the doctors. They are much, much richer. So they have a lot of ferritin. That is how you differentiate. Iron deficiency anemia, genuinely doctors, genuinely poor. And anemia of chronic disease, those pseudo beggars who are saying we don't have money, but they have a lot of money. So now tell me, if you have a lot of money in your bank account, will you ever feel hungry for more money? Nahi na? So the total iron binding capacity is going to be low. That is the difference you have between IDA and anemia of chronic disease. Please note this. An iron deficiency anemia, genuinely very, very poor person and very hungry for money, for iron. But anemia of chronic disease showing itself to be poor, iron and transferrin come hai, but bank account has a lot of money, so that is why the hunger is also less. So basically, one way you look at the bank account, I always tell students that whenever you have to differentiate, kahan chhapa maroge, where will you put a raid? You will put a raid on the bank account. If the bank account is poor, it is a case of iron deficiency anemia. If the bank account is very, very rich, it is a case of anemia of chronic disease. Next raid you will put on total iron binding capacity. Now let me tell you that when I was teaching you total iron binding capacity, it is a mnemonic. Means it is going to be increased or top in iron deficiency anemia, and it is going to be decreased or bottom in chronic disease. How nice a mnemonic. It is increased or top in iron deficiency anemia, and it is bottom in chronic disease. I hope everyone's okay with anemia of chronic disease, because now I'm going to ask you the treatment. Iron deficiency anemia ka the treatment is iron supplements, that I don't have to teach you. But what is the treatment of anemia of chronic disease? Anemia of chronic disease is treat the chronic disease. Don't treat the anemia. Treat the disease, treat the underlying cause. Once you treat the underlying cause, anemia will be corrected on its own. Okay, so don't start giving iron supplements here. That's useless. Treat the underlying disorder and the patient's anyway going to recover after that. The third one that we are going to study in the Sita mnemonic is sideroblastic anemia. Please note, in sideroblastic anemia, sidro means iron. Here there is going to be more and more of iron. Genuinely irony that iron was less, then it was iron deficiency. You understood, iron deficiency hai to anemia to hoga. Now I'm saying iron is more, and then also anemia is occurring. So irony of the iron stories is less of iron is also causing anemia. But why is more of iron causing anemia? Because when you have to make hemoglobin, only iron is not there are two hands which make hemoglobin. Iron is just one hand. So only iron being there is not going to help. The other hand also has to be there. And the other hand is protoporphyrin. Please note that in iron deficiency anemia, so very simply I can tell you, if iron is missing, it is a case of iron deficiency anemia. If protoporphyrin is missing, it is a case of sideroblastic anemia. So basically iron तो है. In this case, what is happening? Iron तो बिल्कुल ठीक है. Protoporphyrin has not come. So why has it not come? The causes are maybe there is some enzyme deficiency. Can you recall from biochemistry which enzyme deficiency? I've taught you in the main videos. All the ALA synthase, ALA dehydratase, all the ALA wala enzymes are basically deficient, and all those ALA enzymes, if the ALA enzymes are not there, this protoporphyrin will not form. So hemoglobin nahi banega. And which vitamin do they need? All of them need vitamin B6. If vitamin B6 is not there, then also all of this is not going to occur. Porphyrin will not form. Similarly, please remember alcohol poisoning and lead poisoning. ये दोनों जो alcohol poisoning तो नहीं होता, alcohol intoxication and lead poisoning. But I have learnt it at this way, that these two poisonings are also going to get me very important questions. Alcohol poisoning and lead poisonings, they are associated with sideroblastic anemia. So that is why, do you remember when we were doing the Sita mnemonic, I had done the Sheetal mnemonic. So lead poisoning actually is a type of sideroblastic anemia only, and you can see that over here. So you realize that protoporphyrin to nahi aaya, but this iron is to in too much. Now iron is saying what to do, I have no one. Iron is there, iron is blinking, I'm here, but that protoporphyrin is not one. So iron kya karega? Iron is in excess, no one, not getting consumed anywhere. Iron is in excess, that results in two things. More of iron in the peripheral blood. In the peripheral smear, you are going to see some bodies known as the Pappenheimer bodies. In the peripheral smear, you see something known as Pappenheimer bodies, which you can see over here, these multiple bodies. You say, ma'am, I don't trust you. Any blue color dot you are picking up and saying Pappenheimer bodies hai, iron hai, aise kaise prove karo. So what is the special stain that you're going to do? Special stain for iron is always one which I've been shouting out since day one, and that is pearls or Prussian blue. Pearls or Prussian blue is the special stain for iron, which is very, very important. Okay? So Pappenheimer bodies matlab they are going to contain lot of iron over here. The next thing that you have to know is, this was peripheral smear. What about in the bone marrow? Why are you calling it sideroblastic anemia? Because you are seeing the presence of ringed sideroblasts. You are seeing the presence of ringed sideroblasts. So again, what stain has been used here? Iron ke liye har jagah same stain. This is also the Prussian blue or the pearl stain that you've used. Ringed matlab, can you see iron has made dot 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 has made a ring like this. So yes, what is the criteria for a ringed sideroblast? At least 5 granules of iron should be there, and at least 1/3 of the nucleus should be covered. 1/3 of the nuclear circumference should be covered. Repeating once again, how many granules should be there? At least 5 granules should be there. So more than 5 dot 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 I can see. And more than 1/3 of the nuclear circumference has to be covered. That is when I am going to call it a case of ringed sideroblast. So for example, यहाँ तो क्या 3/4 is being covered, इधर भी 3/4 is covered, here more than half is covered. So at least 1/3 of the nuclear circumference is covered, and I call it a ring. That is a ringed sideroblast. So please remember, peripheral smear shows you Pappenheimer bodies and bone marrow shows you ringed sideroblast. But what about the iron studies? Sideroblastic, I will say sideroblastic iron deficiency का उल्टा है. Iron deficiency was everything deficient, iron, transferrin, ferritin, and the hunger was very, very high. Sideroblastic is excess, means iron is excess, transferrin saturation is excess, the bank account, everything, iron is in too much abundance, and that is why what is the hunger going to be? Hunger is going to be low. So I can say that iron deficiency anemia and sideroblastic, one is deficiency and one is excess. They are totally opposite. And what was anemia of chronic disease? pseudo beggar. It's showing me that it's very, very poor, but actually what is happening? Actually, it's having a lot of money in the bank account, and that is why it is not very hungry. That is the final profile table on your last day revision that you shall do for the Sita mnemonic for the microcytic hypochromic anemias. Now I'm going to move forward and tell you everything about macrocytic. Megaloblastic is what? Megaloblastic is now going to be the macrocytic anemias. And please note, under this macrocytic anemia, now I have to know that megaloblastic kiska deficiency hai. We all know that. It is a B12 deficiency. It is a folic acid deficiency. B12 deficiency means what? B12 absorption occurs from which part of the intestine? It occurs from the terminal ileum. B12 absorption is going to occur from the terminal ileum, whereas folic acid absorption is going to occur from the jejunum. I am saying that both of them are going to be problematic. That is why patient has megaloblastic anemia. But please remember, for the B12 absorption, is only B12 needed? No. One more thing is needed. There is intrinsic factor which is needed. Who releases intrinsic factor? Pehle to tell me of physiology. What is the other name for intrinsic factor? The other name for intrinsic factor is Castle factor. And who releases it? Someone in the stomach releases it. Parietal cells of the stomach are going to release it. So basically the rule of the universe is that if you want B12 to get absorbed, you will have to give it a partner, that is intrinsic factor. Stomach will give intrinsic factor. So what will stomach do? Stomach will give intrinsic factor, then it will go and bind with B12 to get absorbed in the ileum. So bina intrinsic factor ke, it's not possible. So now I say that what if there are antibodies against the parietal cells? If there are antibodies against the parietal cells of the stomach, that basically means that the intrinsic factor will not be released. And if intrinsic factor is not there, means B12 is also not going to be there. Indirectly, patient is going to be suffering with megaloblastic anemia. So it's a megaloblastic anemia only because B12 is not getting absorbed. But the pathogenesis is very different. B12 ki galti nahi hai. B12 is ready to be absorbed. B12 is saying, please give me my partner intrinsic factor, I will get absorbed. You are not giving him his partner. This kind of an anemia is known as pernicious anemia. So what is pernicious anemia? P for P. Pernicious anemia is that megaloblastic anemia in which B12 is not absorbed because parietal cells may problem hai. Is that okay with everyone? Now you need to know the clinical features. So very important, because it's megaloblastic anemia is what, guys? Megaloblastic hai to anemia hi. Anemia means that the patient is definitely going to have a lot of fatigue, tiredness, hai na? And the patient will be very pale looking, pallor will be there. This is understood. This will be there in any anemia on this planet. But you can definitely see that there is some hyperpigmentation. The first very important point that you see is hyperpigmentation of the knuckles. Hyperpigmentation of the knuckles is something that you notice with megaloblastic anemia. Very, very important. And second thing that you have to know is there could be neurological problems. Now let me tell you, neurological problems are not seen with folic acid. Matlab, neurological manifestations or symptoms are only seen with B12 deficiency. It is not seen with folic acid deficiency. And what neurological problems am I talking about? It is SACD. Every word is important. It is subacute. Matlab, acute bhi nahi hai, chronic bhi nahi hai. Kind of in between. Subacute. Combined degeneration. So you need to understand what is the meaning of this combined degeneration. Combined means that there is a sensory loss also and there is a motor loss also. There is a sensory and motor dono. Sensory loss also and a motor loss, and degeneration means that the spinal cord tracts are getting degenerated. The spinal cord tracts are going to get degenerated. So simple, there is a subacute, combined matlab it's motor and sensory, degeneration matlab spinal cord degeneration is occurring, and this is only a feature of B12 deficiency. This is not a feature of folic acid deficiency. Why is that so? Why is this happening only with B12? Because please remember, going back to your biochemistry, B12 is something that is needed for two very important mechanisms in your body. What are those mechanisms? If you want to convert methyl malonyl coenzyme A into succinyl coenzyme A, you need B12. If you want to convert homocysteine to methionine, you need B12. But when you don't have B12, these are not going to occur. This means methyl malonyl coenzyme में बढ़ता जाएगा, it will never convert into succinyl coenzyme. Similarly, homocysteine will keep on increasing, it will never convert into methionine. What is the defect? Can I say in B12 deficiency, there is going to be elevated levels of methyl malonyl coenzyme and elevated levels of homocysteine? That you've understood? Also, there is less of succinyl coenzyme. Basically, succinyl coenzyme less हुआ तो myelin production is going to get affected. And if myelin production is going to get affected, I've understood the reason of subacute combined degeneration. Neurological problem aa gaya samajh that succinyl coenzyme is not forming. That is why patient has neurological manifestations. So now if I start asking you the changes, if I just put up a very common sense kind of thing, that what are the biochemical things that you will see? If I ask you what will you see with vitamin B12, you'll say, ma'am, this is the joke that you're doing. Of course, it's vitamin B12 deficiency and folic acid deficiency, तो वो तो दिखेगा, right? But what do you think did I just tell you for homocysteine and methyl malonyl coenzyme? Have you understood why they are increasing? As per this pathway that I taught you, homocysteine and methyl malonyl coenzyme can increase. So that also we have understood. Can it be increased in intrinsic factor antibody if it is a case of pernicious anemia? If it is pernicious anemia, yes, the antibody can be there. Can the bilirubin and LDH levels be increased? Yes, because there might be breakdown. Ultimately, जो red blood cell बन रहा है, it is not a nice red blood cell with so many B12 problems, folic acid problems. The B12, the red blood cells are not formed properly. They can break. If they will break, bilirubin and LDH will rise. Finally, there is a test known as the Figlu and Schilling. दो tests हैं which I want you to know. ठीक है, listen to me carefully. What is Figlu test? Figlu test is how I write it. Figlu का full form पहले तो it is, you must have studied it in your biochemistry. It is form-amino-glutamic acid. So you don't have to know the full form of Figlu, form-amino-glutamic acid, but you definitely have to know what are you doing it for. तो Figlu में क्या करोगे? You will take the F of the Figlu and you will take the U. तो बीच का भूल जाओ, take the F because this is a folic acid का test. It is a folic acid test, and what sample will you take from the patient? You will take a urine sample. So how did you learn Figlu, guys? You took the F of the Figlu, the folic acid ka testing hai, and what sample will you take? You will take the urine sample from the patient. The last test that you have to know is the Schilling test. Now when I'm talking about the Schilling test, no one asks you the full procedure nowadays. You need to know it is not a diagnostic test for megaloblastic anemia, because if I have to make the diagnosis of megaloblastic anemia, I have 1 million methods of making the diagnosis. I can test B12, folic acid, homocysteine, methionine, so many things I have. I don't have to rely on Schilling test. Then what am I doing Schilling test for? Schilling test is done to know the cause of megaloblastic anemia. It is done to know the cause of megaloblastic anemia. That is what is very, very important. Okay, so please remember that is what is Schilling's test. Why has megaloblastic anemia occurred? Is it a diet problem? Is it some infectious problem? Is it some intrinsic factor ka problem? Why has it occurred? That is what Schilling's test will tell me. It is not a diagnostic test. It is done to know the cause. Acha, now that I was saying that, I got reminded of one question from microbiology. I said some infection can also cause vitamin B12 deficiency. So which infection can cause vitamin B12 deficiency? It is Diphyllobothrium latum. Diphyllobothrium latum, which is also known as the fish tapeworm. It is also known as the fish tapeworm. That is what you need to know can cause vitamin B12 deficiency. Almost everything is done, only some pictures are left. There are like 4 pictures I want to show you, and megaloblastic is done. Firstly, I told you megaloblastic anemia is what kind of an anemia? It is a macrocytic anemia. So can you see if these are normal red blood cells? I can very well visualize that these red blood cells have become very, very big. They are macrocytic, right? So the first point that you have to know is macrocytic. Not only are they extremely big cells, they're also going to become a little oval. So the second finding that I have over here is a macroovalocyte. The second finding that I have over here is a macroovalocyte. The third finding are these single dots. These single dots that I'm seeing over here, these are referred to as the Howell-Jolly bodies. This gets you a lot of questions. So listen to me very, very carefully. When I'm talking about Howell-Jolly bodies, question number 1 is that what are they made up of? They are made up of DNA remnants. They are little dots of DNA remnants. Question 2, how many dots are they? They are single. They are single dots. They are not multiple. देखो every RBC has one dot. So I have learned अभी exam time है, you don't have to get distracted. So you are happy and jolly to be single. Happy and jolly to be single only till the exam time. After that you are okay with mingling also. So they are usually single. And finally they will ask you that under which condition do you see it? So the next question that you have to know is where do you see it? So of course, number one, I'm reading the anemia over here, and that is the megaloblastic anemia. And the second one that we have to know, which they ask you a lot of questions on, is post-splenectomy. Even in post-splenectomy patients, you're going to see it. And please remember this question. Post-spleen removed, what will you see in the blood? Favorite most question. Spleen removed, what am I going to see in the blood? Hobble jolly bodies. Coming to the fourth one, what do we see over here? The very famous figure of 8 appearance, that is the Cabot ring. So what is the composition of the Cabot ring? Chota sa patla sa thread hai, right? You can, if I have a thread, I can turn the thread in any direction. Na? So what is it? It's a thread, means it's an arginine-rich mitotic spindle. It's an arginine-rich mitotic spindle. So spindle, patla sa thread, I can make it 8, I can make it 0, I can make it D, any shape of my choice. Here what they've shown me is the figure of 8, but it can be any shape. Like I said, 8, 0, D, B, any shape is possible. So what all have I done? Macrocyte, macrovalocyte, Hobble jolly bodies, Cabot ring, but all of these were RBC changes. What about WBC changes? It shows you the very famous hypersegmented neutrophils. It shows you the hypersegmented neutrophils. So they ask you what is the criteria for hypersegmented neutrophils. Please note, HS neutrophils, either I am seeing 5% of neutrophils with 5 lobes, 5. So 5% neutrophils have 5 lobes. Or even if one neutrophil has 6 or more than 6 lobes. So either 5% of the cells have 5 lobes, or even if one neutrophil has 6 or more than 6 lobes. So try to count over here, guys. If I see over here 1, 2, 3, 4, 5, 6, 7. This neutrophil over here is showing you 7 lobes. Tell me, do you want to count any more? No, I said even if one neutrophil shows you 6 or more than 6 lobes, matlab it is hypersegmented neutrophil. If it would have been showing only 5 lobes, then you would have counted more. You would have said, ma'am, at least 5% cells should have 5 lobes. So ya to 5 chalega, or even if one has 6 or more than 6 lobes, that is when that is going to have hypersegmented neutrophils. So your microcytic and macrocytic anemias are done. Now let's go on with our discussion of the hemolytic anemias. Please note that we are going to have a tabular form starting from hereditary spherocytosis, G6PD deficiency, sickle cell, thalassemia, PNH, autoimmune hemolytic anemias. These 6 or 7 anemias we need to do in a tabular manner. So if you overall look at it, there are going to be 6 or 7 anemias with 10 to 12 slides in how we'll wrap it up. So when I'm talking about hemolytic anemias, the red blood cells are going to break down. Where are the red blood cells breaking down? Are they breaking down in the blood vessels, that is intravascular hemolysis? Or they are breaking down outside the blood vessels like in the spleen and the liver, and that is going to be extravascular hemolysis. That is going to be the difference, right? So I'll keep telling you gradually which is IVH and which is EVH. But before I begin, the first part of it that I'm going to start with is the RBC membrane. Please note that in the RBC membrane, we have something known as molecules called spectrin. You can see alpha, beta spectrin. So remember, spectrins are the one that maintain the shape. If they ask you which is the protein responsible for maintaining the biconcave shape, so remember shape ke liye, look at the words that I have highlighted. So shape ke liye, it is SPE, and that is going to be spectrin that maintains the shape of, easy to learn, shape ke liye SPE, that is spectrin. Now I say, coming back, attached to the spectrin, I can see a lot of molecules. I just want you to be familiar. There's something called encheirin, band 4.2, band 3, there is glycophorin A, 4.1, actin, ye sab molecules hai, right? So now if I ask you if they start undergoing a problem, if I say that there is a problem in encheirin, that is going to result in hereditary spherocytosis. Please note, the most common mutation in hereditary spherocytosis is going to be encheirin. But you'll say, ma'am, shape कौन maintain कर रहा था? Shape was spectrin. If that spectrin undergoes a mutation, then what will happen? Then also hereditary spherocytosis can happen, but a different type of hereditary spherocytosis, that is autosomal recessive hereditary spherocytosis, which tells me that hereditary spherocytosis is actually what? Hereditary spherocytosis is an autosomal dominant disorder, primarily autosomal dominant. So the most common mutation in that autosomal dominant disorder is enchirin, but when there is a chota sa spectrin problem, there is a minor condition, that is autosomal recessive HS, that can happen. Out of these, which is the most abundant protein? Glycophorin A is the most abundant, and that is also the protein that is never ever mutated in hereditary spherocytosis. There is no glycophorin A mutation known in HS. Lastly, what is band 3 defect? The way you write a 3, it looks as if you're trying to pinch something out. Dono 3s aise something in a pincher or a pincer cell. Where do you see? How do you see pincer cells? Pincer cells are seen with band 3 defect. So simple, jaldi se revise karo. Who maintains the shape? Shape is going to be by spectrin. Spectrin se HS hoga, but HS will be the rare wala, autosomal recessive wala. The most common mutation of HS is enchirin. Now, which is the most abundant? Glycophorin A, that will never be mutated. That is also glycophorin A. And what does type 3 or band 3 cause? Defect consa? That is the pincer cell. Out of these, of course, I am interested only in hereditary spherocytosis for the time being, and that is what I am starting my discussion with. So tell me, which is the most common defect? Right now, padha, it's a quick revision, and that is going to be enchirin. The most severe matlab they are talking about autosomal recessive wala. What is the most severe autosomal recessive defect? Spectrin defect. And which is the defect which is never seen? Right now we studied, it is glycophorin A. Please note, hereditary spherocytosis is a type of extravascular hemolysis. Whatever is happening is outside the blood vessels, means who is breaking the cells? The spleen and the liver are breaking the cells. So tell me, if the red blood cells will be broken. So for example, if these are red blood cells and they are now going to be broken like this, will there be jaundice? Of course, there's going to be jaundice. Who is breaking them? Of course, the spleen is breaking them. So there is going to be splenomegaly also. And agar jaundice, bilirubin hoga, so of course there are going to be gallstones as well. So what is the classical triad that you have in a case of hemolytic anemia? Anemia, that is hereditary spherocytosis. It is a hemolytic anemia, but other than that, patient has jaundice, splenomegaly and gallstones. Everything is happening outside the blood vessels. It is a extravascular hemolysis. Spleen is coming and breaking your cells. Is your bone marrow going to keep quiet? No, na. Your bone marrow will increase the reticulocyte count. Your bone marrow will increase the reticulocyte count. So what is going to be the parameters? Socho. Now, what are these spherocytes? Let me show you spherocytes. Can you see? This is how the spherocytes look like. So what are the properties of a spherocyte? Rather than spherocyte, we will call them microspherocytes, because this word tells me that they are chota in size. They are smaller in comparison to a red blood cell. They are smaller to a regular red blood cell. They are micro, chota. Not only that, why are they totally pink? Why are they covered with hemoglobin? There is no pallor. They are totally covered with hemoglobin. Why? Because they are very, very concentrated. Basically, these cells have had a lot of water loss. All the water has gone out of these cells, as a result of which the hemoglobin concentration, see, if I remove the water from a place, that area will become very concentrated, na? Because so much of water loss has happened, the hemoglobin is extremely concentrated. So tell me something. I call them microspherocytes. That size is chota, so obviously MCV is low. Then I'm saying water loss has happened, so the hemoglobin is very, very concentrated. This means MCHC is high. Everyone's understood? Repeating, because I said they are smaller, I'm saying MCV is low, and because I'm saying that the water is lost and the hemoglobin is concentrated, so MCHC is high. But what did I also say? That spleen is breaking your cells. These are chota cells. I'll write it down like this. These chota cells are there, microspherocytes. Because they are being broken down, what is your bone marrow doing? Your bone marrow is making big cells. The big cells are reticulocytes. So can I say the patient is going to show chota spherocytes and big reticulocytes? Is there going to be a change in the RDW? Yes. You understood the reason? The small cells that you're seeing over here are the spherocytes, and the big cells that you're seeing over here is what the bone marrow is trying to make, reticulocytes. This means there is a variation. RDW is more. Coming to aplastic crisis, what do we mean by that? Aplastic, guys, what is the meaning of aplastic? Bone marrow says shut off. Bone marrow says I am not going to work. So RBC, WBC, platelet, everything stops working. When does that happen? If a patient gets infected with parvovirus B19, that is when aplastic crisis can occur. Next, what is the screening test for hereditary spherocytosis? I think everyone knows osmotic fragility testing. I'll show you the graph of OFT. Osmotic fragility testing has shown me that H for H, hereditary spherocytosis is going to be high osmotic fragility. It's going to show us high osmotic fragility. Repeating, hereditary spherocytosis, high osmotic fragility. So look at this graph. You can all see that over here I've got the concentrations of NaCl. And over here, I've got the percentage of RBC lysis. I want to find out at how much NaCl, how much of RBCs are breaking. So please note that normal person, if we just pick up a normal person for the time being, in a normal person, RBC start breaking. The normal person mein lysis is going to start at what concentration? Lysis is going to start at 0.5% of NaCl. When do I see 100%? देखो 100% lysis कब हुआ? At what concentration? Somewhere around is going to be at 0.3. So this is going to end at 0.3. That is a normal osmotic fragility. But in hereditary spherocytosis, I am seeing high fragility, very, very fragile, very, very weak cells. Can you see? The graph has shifted to the right. The cells are breaking even at 0.7% NaCl. So hereditary spherocytosis, the shift is going to occur to the right. The graph is going to show you a right shift. And let me tell you, because these cells are high osmotic fragility, they are very, very fragile. Do you know when does the graph shift to the left? In which situation is the graph going to shift to the left? And that is thalassemia. So remember, the left shift is going to occur in cases of thalassemia because thalassemia cells have low fragility. Low fragility matlab less fragile, less weak. Less weak matlab strong na. So I have learned thalassemia cells are very, very tough. Now you will know which is weak and which is tough. So thalassemia cells are very, very tough, whereas hereditary are highly fragile. Highly fragile means very, very weak. याद रहेगा. So hereditary में shift to right होगा and thalassemia is going to be shift to left. So your screening test is done. But what is the confirmatory test? There is a test called the EMA. EMA stands for eosin 5 maleimide testing. Eosin 5 maleimide is now said to be the confirmatory test. What is the treatment going to be, guys? The graveyard was the spleen. The person who was killing everything was the spleen. So now it's removing of the graveyard. That is important. The treatment is going to be splenectomy. That is your one go-to flashcard for hereditary spherocytosis. Moving on to the next. Now we are going to come across and talk about, because ye kuch shape ka problem tha na, I'm going to tell you the shape problems over here. So we have acanthocytes and echinocytes. What are they also known as? There are also some shape problems which we quickly, let's finish off with this only. Acanthocytes are known as spur cells and echinocytes are known as Burr cells. Many students get confused between their names only. So dekho, the way you write E is the same way you write B. So please note, echinocytes are known as Burr cells and acanthocytes are known as spur cells. ठीक है? तो firstly E and B हो गया and acantho. Acantho कैसे याद करेंगे? Acantho is spur. Spur means spiky. So how are they going to look like? Obviously, over here I can see lots of spikes coming out. So this must be the acanthocyte. I can see spikes. Whereas here I can see that the cell is very, very blurred. ऐसा zigzag. तो blurred वाला Burr cell, blur वाला Burr cell or echinocyte. Easy to identify. Acanthocyte is spiky spur, and echinocyte is Burr. Burr matlab blur. ऐसा zigzag blur. So you've understood the identification. How are the conditions associated? So remember, A for A. Acanthocyte is going to be seen in A beta lipoproteinemia. Acanthocyte is seen in conditions of A beta lipoproteinemia. Very, very, very important. Whereas echinocyte को क्या बोलते हैं? Burr cell. So what are the alphabets that I've highlighted? B for Burns. You see it in Burns patient. U for uremia, kidney failure, uremia patient. And E for if there is excess EDTA used, EDTA changes. So please note this. Burr cells are seen in Burns, uremia and EDTA changes. And acanthocytes are going to be seen in A beta lipoproteinemia. These shape related things are done. Now we are going to go on to enzyme deficiency. Which enzyme deficiency is the hemolytic anemia that we have to know of? G6PD. G6PD is a combination of extravascular and little bit of intravascular hemolysis also can occur, but predominantly extravascular. Now you tell me the cause. You'll say, ma'am, is this a joke? Of course, you are telling me the G6PD is deficient, so that is the deficiency. But this is an intermittent disorder. Even if someone is having G6PD deficiency 24/7, he's not going to show symptoms. He will show symptoms because of certain precipitating factors. What are the precipitating factors? That is, if someone, remember these two factors very carefully. What if someone consumes fava beans? Fava beans are not very commonly consumed in many countries. It is something which you see in Mediterranean region. Favism, fava beans, Mediterranean region mein hota hai. And secondly, if there is consumption of anti-malarial drugs, if there is consumption of anti-malarial drugs by these patients, then they will start showing you the symptoms. So this is an intermittent disorder. This doesn't show you symptoms all the time. Only when the person will consume fava beans or anti-malarial drugs, then this is going to show you the symptoms. So this means extravascular hemolysis. Who is going to do the hemolysis? Spleen. But is the spleen working 24/7? You'll say, no ma'am, spleen is working 10 days it works and 20 days it is chutti. 10 days it works, 20 days chutti. That is how spleen is working. So there is no splenomegaly that you'll see. There is no splenomegaly that will be noted because the spleen is not working 24/7. It is not a 24/7 disorder. What are the blood findings? At the end of the day, person doesn't have G6PD, which means that there is going to be a lot of stress in the body. There is oxidative stress that occurs in the body. Do you know what happens because of oxidative stress? Heinz bodies are formed. So first and foremost, can you see this film over here where these 1 to 2 bodies are noted? These are all said to be the Heinz bodies. Now, what is it about Heinz bodies that you have to know? You'll say, ma'am, sabse pehle to this background is a little different. Usually red blood cells are red. Ye kitna dull sa grey color ka background hai. Because Heinz bodies are not stained on Romanovsky. Please remember, they are not stained on Romanovsky stains. This is very, very important. So you will now ask me that if they are not stained on Romanovsky, how am I going to stain it? So please remember, they are going to be stained on crystal violet. Please note, you will have to use crystal violet stain. This question is very, very important. Please, for the Heinz body, use crystal violet. What are these Heinz body? Why are they not being stained on Romanovsky stain? I'll say, itna zyada stress ho gaya tha na, the G6PD was not there, your body was under so much of stress, your hemoglobin got kharab, the hemoglobin got denatured. There is denatured hemoglobin that is going to be there, and that is the composition of the Heinz bodies. So these ... are spoiled hemoglobin, and that spoiled hemoglobin will not be stained by Romanovsky. Spoiled hemoglobin ke liye you need crystal violet. What are the cells that you see? I think everyone knows G6PD deficiency shows you the bite cells. They will ask you the other name of the bite cells. Bite cells are also known as what? Degmacyte. Students get confused. Bite cells are degmacyte or dacrocyte or drepanocyte. I will tell you lots of D's. So remember, dog bite. Dog bite. So degmacyte are the bite cells. Coming to next, 2 screening tests which you quickly have to just mug up. Only mug up because no one does them nowadays. There is a fluorescent spot assay and a methemoglobin reduction test. As I said, no one does it nowadays. Nowadays, the confirmatory testing is just G6PD assay. Just measure the levels and that's about it. So no one does these testing. Just know the names. Fluorescent spot test, methemoglobin reduction test, they are for G6PD deficiency. But karna kya hai? You have to do confirmatory by measuring the G6PD levels. Okay. Moving on to the next one, we have something known as PNH, paroxysmal nocturnal hemoglobinuria. This is the only acquired RBC defect that we have. Means you don't get it from your mom or your dad. This is not inherited. G6PD was inherited. Hereditary spherocytosis was inherited. This is not inherited. This is something you've acquired. This hasn't come from your mom and dad. So what is the defect that I see? I think we all know the gene that is defective is a PIGA gene defect. Because the PIGA gene defect is there, what anchors are not formed? The anchors that are not formed are the GPI anchors. Anchor kya hota hai? Anchor holds on to something, like anchor of a ship. It holds on to the ground or it holds on to the bottom of the sea. So anchor holds on to something. I'm saying anchor is not there. If anchor is not there, who will not be held on to? CD55 and CD59. What are the other names of CD55 and 59 that they ask you in the paper? CD55 is also known as DAF. And CD59 is also known as MERL. Smaller number, smaller name, bigger number, bigger name. DAF and MERL are not there. CD55 and CD59 are not gonna be there. So repeating once again, guys, the problem in PNH is that PIGA gene will not be there, so the anchors will not form, no one to hold on to CD55 and 59, as a result of which patient has nighttime hemoglobinuria. Nocturnal hemoglobinuria, patient will wake up at night and say that I pass red color urine at night. I'm passing red color urine at night. That is what you have. Please note, hemoglobinuria, if blood is coming in the urine, what comes in the urine? From where does a thing come in the urine? Blood se na? Blood say via the kidney something comes into the urine. So can I say if hemoglobin is coming into the urine, it's coming via the blood only? Means this is a case of intravascular hemolysis. Obviously, if something is coming in the urine, it's coming from the blood only, na? So it's a case of intravascular hemolysis. So how will I do the testing of this? Pehle to ratta wala screening tests. Ham's acidified serum test and sucrose lysis test to rat lo. That is that you have to do ratta because no one does it now. Let's go through it. Ham's acidified serum test and sucrose lysis test. The test which is being done under screening nowadays is gel card test. I'll tell you how to identify. Look at this. Just focus on the gel card of the first person as of now. Abhi first wale ka gel card pe focus karo. Don't focus on anything else. So what is the first gel card showing me? Do you all remember how to study a gel card? Do we all know how gel card analysis is going to be done? So we had studied that if you see something at the top, तो top पर जो line आएगा that is going to be positive, and नीचे at the bottom when you see a line, नीचे जो line आएगा that is going to be negative. So please remember, top पे positive and नीचे negative. Over here they have said this is Merle bigger वाला name, मतलब CD55 59. DAF छोटा वाला नाम, this means CD55. छोटा name, छोटा number, bigger name, bigger number. I am seeing a line at the top over here, मतलब positive. 59 है. I am seeing a line at the top over here, मतलब positive, means 55 and 59 are positive. ये तो normal person है. Someone having 55 and 59 is a normal person. Let me look at the other scenario that we had erased. Now over here, what did we see? We had seen the line is not at the top, the line is at the bottom, the line is at the bottom. नीचे 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 मतलब negative negative. When I say negative negative means CD55 and CD59 are negative. When CD55 and 59 are negative, this is a case of PNH. Everyone's understood? Top positive, niche negative. That's how gel card is. So the screening tests are done, but that is screening. What is confirmatory? Flow cytometry and flare. FNF, flare and flow cytometry. Flow and flare are confirmatory testing. So please note, flow cytometry tests for what? Flow cytometry says that I am testing for CD55 and CD59. तो flow cytometry यहाँ पर CD55 and 59 का testing करता है. Whereas what does flare test for? Flare tests for the GPI anchors. Flare is going to test for the GPI anchors. So tell me one thing. Problem actually कहाँ है? Problem is in CD55 or 59, or the problem is that the anchors are not there and that is why CD55 and 59 can't be held? Real problem is anchors are not there. So nowadays they are saying flare is better because flare is going to go and test directly the problem, and that is the GPI anchors. Flow cytometry indirect कर रहा है. Flow cytometry is testing CD55 and CD59, right? But yeah, both of them are confirmatory tests. What are the complications? So number one complication is patient can have PNH is associated with thrombosis. There can be hepatic vein thrombosis, cerebral vein thrombosis, blood clot. मतलब deadly तो ये है. Second, it's not only deadly, it's very, very moody. Why do I think it's very moody? It says either my bone marrow will stop working, या तो बिल्कुल ही quiet aplastic anemia, or my bone marrow will start working a lot, that is acute leukemia. So two things, either the bone marrow will stop working at all, aplastic anemia, or it is going to be too much of work, that is acute leukemia, very moody. Either it will not talk or it will talk a lot. That is what is PNH. What is the treatment? Guys, we give a drug called eculizumab. Eculizumab is a monoclonal, you can see that. It's a MAB category, monoclonal antibody. Eculizumab is the drug that is given, and that is a recent medicine question that you have to know. So PNH is done. What is the next group of disorders that we are going to start with? Hemoglobinopathies. We quickly have to study about sickle cell anemia and thalassemia. These are the two hemoglobinopathies that you guys have to know. So when I'm talking about first one, let's begin with sickle cell anemia. Under sickle cell anemia, please tell me what is the cause. I think we all know that is at the beta 6 position. What is going to go? Glutamate will go, and what is going to come? Valine is going to be welcomed. So remember, glutamic acid is going to go away and valine is going to be welcomed. That is the defect of sickle cell anemia. तो कैसा दिखेगा? Quickly look at sickle cells. These are all the sickle cells that you have. So sickle cell का दूसरा नाम, sickle cell is also referred to as drepanocyte. Sickle cell is also known as drepanocyte, and I've already told you sickle cells are very, very sticky. Sickle cells are very, very sticky. They tend to all stick to each other. Stick to each other matlab they will cause occlusion. They are going to result in occlusion. So imagine they go and cause occlusion in the vertebra. Vertebral arteries. What is the vertebra going to look like? It's going to be fish mouth vertebra. They go and cause occlusion in the vertebral arteries, fish mouth vertebra. They go and cause occlusion in the spleen. The spleen will say, someone is sitting in my blood vessels, blood supply gaya. Spleen is gonna get damaged. Autosplenectomy. Autosplenectomy, very, very famous question, is seen with which of the following hemolytic anemia? Sickle cell anemia. And finally, the skull and the face. I want to show you 2-3 clinical findings over here. The skull and the face, especially the skull, is going to show you something known as crew cut appearance. The skull is going to show you crew cut appearance. Let me tell you, crew cut appearance I will show you in a while because it is seen with sickle cell anemia as well as thalassemia. दोनों में दिखता है. I'll tell you the concept. अभी बस रट लो for the timing. Okay. So skull shows you crew cut appearance, vertebra shows you fish mouth appearance, and spleen shows you autosplenectomy. All of these are because the cells are sticky. So they are creating a problem. So what are the tests that you will do? Number one, on a peripheral smear, what were you seeing? You were seeing the presence of sickle cells. देख लिया ना? Sickle cells were known as what? They were known as drepanocytes. What is the next test that you can do? So the next test is the sickling test, which they really love asking you. First, let me tell you, for the sickling test, I am using a chemical. What chemical? This question is very important. The chemical used is 2% sodium metabisulfite. 2% sodium metabisulfite is what is the chemical that we have, and you can see it over here. You can see this sickling ho gaya. This is why has it happened. So if they mention sickling test, they will ask you by adding which chemical have I made all of them sickled. I have made them sickled by adding 2% sodium metabisulfite. Coming to the third one, they will ask you HB electrophoresis. For HB electrophoresis, we all have to learn a mnemonic called HAFSA. Very, very important. What is the mnemonic HAFSA that you have over here? Please note, this is HB electrophoresis. This is a case of HB electrophoresis. And what do we have in HB electrophoresis? One side is the positive end, that is the anode. One side is the negative end, that is the cathode. And what is it about the HAFSA mnemonic that I'm telling you? So from the anode to the cathode, we have actually chota sa hemoglobin hota hai, H. Sometimes you get it. Hemoglobin H, then hemoglobin A, then hemoglobin F, that is fetal, then sickled, and then A2. So from the anode to the cathode, it is HAFSA2. That is what you mean by the HAFSA mnemonic. But in that, there is a little bit of overlap. Please note, S overlaps with D. Hemoglobin S is going to overlap with hemoglobin D. And you can see this A2 is overlapping with a lot of things. It is overlapping with hemoglobin C, A2, E and O. ये सब overlap करते हैं. कैसे याद करेंगे? How have you written cathode? C for, okay, C will use, ma'am, C is reminding me of hemoglobin C. AT is reminding me of A2. Then O is reminding me of hemoglobin O, and E is reminding me of hemoglobin E. So don't I know what are the hemoglobins that are going to come at the cathode? Life has become again very, very simple. Matlab hemoglobin C aayega, then hemoglobin A2 aayega, then hemoglobin O will come, and hemoglobin E will come at the cathode. So now the full HAFSA mnemonic is done. From the anode to the cathode, it is hemoglobin H, A, F, SD come together, and A2 ke saath to the full cathode story will come. So if I say there is a patient who has all his hemoglobin over here, you will say this is the SD wala band. Either it is hemoglobin S, that is sickle cell anemia, or it is hemoglobin D, that is hemoglobin D is known as what? Hemoglobin D is known as Punjab. Now second scenario, if I say this is your patient, some hemoglobin is over here, matlab adult wale range mein. Some hemoglobin is over here, matlab sickle wale range mein. So you will say, oh, this is a case of sickle cell trait. Little adult, little sickle. So this is a case of sickle cell trait. Whereas when all of it was sickled, When all of it was only sickle, this was a case of sickle cell anemia. Everyone's understood how to differentiate. Sickle cell anemia mein all the hemoglobin is sickle. Sickle cell trait mein there is a combination, little bit adult, little bit sickled is going to be there. So that is what you see with HB electrophoresis. But if someone asks you what is the gold standard that you have, HPLC is the gold standard for all hemoglobin disorders. Coming to the treatment, we give a drug which is known as hydroxyurea, and the purpose of giving hydroxyurea is that it will increase the fetal hemoglobin. If you increase the fetal hemoglobin, that means that the oxygen affinity, fetal hemoglobin has a lot of oxygen binding ability. Now, we all know that ऑक्सीजन ज्यादा होगा, this means the sickling will not occur. Sickling का problem happens in hypoxia. If you don't let hypoxia occur, अगर oxygen ठीक रखोगे, cells are also gonna be fine. So how do I keep the oxygen fine? By increasing the fetal hemoglobin. By which drug? That is hydroxyurea. Having discussed this, now we move on to thalassemias. What are thalassemias? Alpha thalassemia, beta thalassemia. Let me start off with alpha thalassemia. Please note there is an entire table that wraps up alpha thalassemia. When I'm talking about alpha thalassemia, A for A, this is because of alpha gene mutation or deletion. You will say, ma'am, how do I learn this? Hai to deletion, but how do I learn it? Alpha gene will become absent, absconding, deleted. If alpha gene goes absconding, not mutation, deletion, absconding, deletion, that is when alpha thalassemia occurs. So, remember that a normal person has 4 alpha genes. A normal person has 4 alpha genes. If one gene is deleted, there is not going to be any problem in anyone's life. It is asymptomatic. If 2 genes are deleted, like you can see over here, 2 genes are deleted, then also not a problem. T2, matlab 2 genes are deleted, 2 matlab alpha thal trait. So trait mein 2 are deleted. When 3 genes are deleted, please remember when 3 genes are deleted, that is when we have something known as HbH disease. And you know what is the composition of HbH disease? It is beta-4 tetramers. The hemoglobin formed in this person is beta-4 tetramers. And this is going to show you the golf ball inclusions that I will be showing you in the next slide. But before I show you golf ball inclusions, know the story behind it. So please remember, he is a boy who is playing golf at 3 a.m. in the morning. Why is he playing golf? Why would someone play golf at 3 a.m. in the morning? A heartbroken person. A heartbroken person whose girlfriend has left him. So ye alpha genes have deleted. Na? Alpha genes have gone away. So this boy beta 4, this is just B for boys. So boy is left alone. Ideally it was alpha beta combination. Now that alpha girl has run away. So this girl has run away. How will this boy get over his breakup? He is trying to divert his mind. So he, who is a boy, is playing golf at 3 a.m. in the morning. Golf ball inclusions. Golf ball inclusions. So what is it? So as soon as you see jo ... golf ball inclusions, you will say, oh, he, that is HbH disease, he is a boy, beta-4 tetramers who is playing golf at 3 a.m. in the morning. 3 deletions have occurred. That is how you learn the story. Finally, when all 4 get deleted, this is not compatible with life only. This is going to result in intrauterine death, and this is known as HB Bart's disease. This is known as HB Bart's disease. Fetus, the fetus is going to die in utero. So how I have learnt it? Barbad fetus. Barbad fetus is HB Bart's. Barbad fetus means intrauterine death, and fetus has fetal hemoglobin, na, to wo gamma-4 tetramers hoga. So another way of learning it is, there is a Barbad fetus, Gaya fetus. That is how I learnt it. Barbad fetus, Gaya fetus. Barbad fetus means HB Bart's is going to result in the fetal death, and Gaya fetus, that is going to be fetal death. So sometimes related to such serious topics, you have to make lighter mnemonics in order to understand it, right? So 1 gene deleted, not a problem. 2 deleted, 2 hoga to trait, T2, 2 trait. Then 3 deleted, so he is a boy who's playing golf at 3 a.m. Ho gaya? And 4 deleted, not compatible with life. HB Bart's, gamma-4 tetramers. Alpha thalassemia is done. The last hemoglobinopathy that we have to know is going to be beta thalassemia. So please note one thing, beta thalassemia, before I come to these different tables of major and minor, beta thalassemia ka genetics is very important, and beta thalassemia is beta gene badalna, mutation. Beta gene getting mutated. So everyone, what was alpha gene? Alpha thalassemia mein alpha gene absconding ho raha tha, deletion ho raha tha. Beta gene is going to be badalna. Badalna means mutation. You'll remember it. So what is the most common mutation that you have? You have a splicing mutation known as IVS15G2C. As I say it, I know it's going to be so difficult for you to learn. Only one. There's a long list. In India, I'm telling you to learn one, which is the most common mutation that you see in India. Remember IVS. IVS matlab intron. Intron में codon 15 पे G2C, G changes to C. IVS15G2C is the splicing mutation. Is there any frame shift mutation? Yes, at codon 8, 9 and 41, 42. The FMG students can skip this information. NEET PG INI के लिए तो it's important. Plus 8, 9 and plus 41, 42 locations पे frame shift. So everywhere mutation, mutation, because beta gene का बदलना, mutation is beta thalassemia. So now examiner will ask you, which is the only deletion possible in beta thalassemia? 619 base pair deletion. 619 base pair deletion is the only deletion possible in beta thalassemia. Very important question. So we've understood it, and now I need to know that beta thalassemia is major, intermediate, minor. My advice is, at least in this rapid review, focus on major and minor. My main concern will be on major and minor. Major is also known as Cooley's anemia, and this patient is always going to be transfusion dependent. The patient is always transfusion dependent. So why is the patient transfusion dependent? Because there are no beta chains. Beta thalassemia, beta chains are gone. Look at his hemoglobin. His or her hemoglobin is very low, very severe anemia. Only 3 to 5 gram hemoglobin in there. So pallor is there, jaundice is there, splenomegaly is there. So because of all these conditions, the patient is always dependent on blood transfusion. He or she will keep on getting blood transfusion. You must have seen thalassemia blood banks hote hain. They need repeated blood transfusion. More the number of blood they will get, more their iron will keep on increasing. So these are the people who are going to have an elevated iron profile. Iron overload will end up happening because they receive so many blood transfusions. Now finally, how will you do the diagnosis? We all know what is the gold standard. Gold standard is HPLC. So what is the HPLC finding in beta thalassemia major? It is HbF is elevated. More than 90% is going to be HbF in these patients. Normal hemoglobin nahi hai. Adult hemoglobin is not there. That is why there's a problem now. More of it is 90% is fetal hemoglobin. So this is definitely quite a dangerous situation. Body is not making adequate blood. So now what is the patient going to present with? Number one, in the skull we see the crew cut appearance. Remember I told you crew cut appearance is seen in sickle cell anemia and thalassemia. You can see this crew cut. The boys used to get this crew cut. That is why they gave it a crew cut, and this is also known as hair on end appearance. So crew cut or hair on end appearance basically means the same. Other than that, they have very prominent cheekbones. So what is this known as? This is known as the chipmunk facies. We see the presence of chipmunk facies. Finally, what do you see microscopically? T for T. Remember thalassemia major mein we see the presence of target cells or podocytes. Target cells or podocytes are seen in thalassemia. So the cell is going to look like this with a dot in the center, like bullseye target ki tarah. So target cells are going to be seen in thalassemia. Now going back, this was all about beta thalassemia major. Now my advice is that you also have to study beta thalassemia minor. Minor में तो minor सा problem है. That is why these patients don't even know they have this condition. Minor सा problem. They are asymptomatic. Hemoglobin भी okay moderate है. मतलब 8 and above, this patient is not going to have any symptoms in that ना. So now you will say that iron profile is also coming normal. Ma'am कोई problem लग ही नहीं रहा. How will I pick up this patient? Symptoms are not there. Hemoglobin is also well above 8 or 9. Iron studies are also coming normal. But at the end of the day, problem to hai. There is a genetic problem na. So what are you going to do? You're going to do something known as the differentiation. To differentiate iron deficiency anemia from beta thalassemia minor. Why? Both of them are microcytic hypochromic. Both of them were under the Sita mnemonic. So remember, you do Menzer index. Menzer may take the M and take the R. Remember, Menzer index is defined as MCV upon RBC. If it comes out to be more than 13, it is iron deficiency. If it is less than 13, it is thalassemia. How will I learn it? Thalassemia ke liye you will learn it as thalassemia. Thalassemia tells you less than 13. So less than 13 is thalassemia, more than 13 is iron deficiency anemia. Next, RDW. RDW will be elevated in iron deficiency anemia, normal in thalassemia minor. Why? RDW tells me what? Variation. Na? तो iron तो diet का problem है. Sometimes I told you ना, sometimes the cells will be small, sometimes the iron will be less, तो the cells will be small. Sometimes iron will be more, the cells will be big. तो iron पे dependent है, diet पे dependent है, तो RDW will be more, variation होगा. Whereas thalassemia तो is a genetic problem. All throughout life, छोटा छोटा छोटा, same size. All throughout life you will get the same size. So RDW is normal. Coming to the confirmation, how do you do the confirmation of thalassemia minor? Remember, the HbA2 levels above 3.5% has to be documented. Till the time you don't get this report in hand, never ever give the diagnosis of thalassemia minor to anyone. So this report has to be in your hand, and that is going to be the final confirmatory point for thalassemia minor. So that is what I'm saying. When everything is coming looking normal, patient is also not complaining of symptoms. Number one, you say, ma'am, I have done your Menzer index. Your Menzer index is coming less than 13. Patient says, I don't have any problem. What are you talking? You will say, hang on, your Menzer index is coming less than 13. मुझे suspicion हो रहा है that you have thalassemia minor. Let me do one HbA2 levels and find out. HbA2 levels came more than 3.5 and you confirmed that she had a case of thalassemia minor in the story. I hope everyone's okay. One last part about thalassemia that you have to know is a very famous test known as the Nestrov test. Now, what is it about Nestrov that you need to know? Of course, I've told you a little bit about it. I'm going to tell you a little extra. This is a naked eye test. You don't need any microscope for it. You are performing it in a single tube, okay? And this is a red cell osmotic fragility testing. So tell me something. Thalassemia cells, are they weak or are they tough? What did I teach you? Thalassemia cells are very, very tough. Are they going to break? If you put any normal saline or anything in them, you'll say, no ma'am, they don't break. So remember, if you start seeing the lines at behind, this means to cell to gaya. If I keep a test tube and behind the test tube you can see everything, you'll be like, ma'am, cells have broken. So if the lines are visible, this means cells are gone, cells are broken, and that is what you see with normal. In a normal person, a normal person's blood cannot survive so much of saline. In this you've added saline. Normal person's blood cannot survive so much of hypotonic saline. But thalassemia cells are very tough. You put the test tube and you say, ma'am, पीछे का line नहीं दिख रहा. I can't see the line because the cells are still there. The cells have not broken. So this, I say, when the lines are absent or the lines are not seen, we start thinking this is a case of thalassemia. So I am going to add on to my mnemonic. Did I just tell you thalassemia को हम thalassemia कहेंगे because I told you TH for 13 and less for less than 13, है ना? Now I'm going to add into that mnemonic and tell you that AL of thalassemia is going to tell me absent lines. That is going to tell me absent lines, which means on Nestrov, lines will not be seen, and on Menzer, less than 13 is going to be the situation. Please remember this for thalassemias. That wraps up your alpha, beta, dono thalassemias. These were all the RBC defects. The last part of RBC that you have to know, guys, is going to be autoimmune hemolytic anemia, and we'll quickly wrap it up with this one flowchart. When I'm talking about autoimmune, you've understood one thing, that it is to do with autoimmune antibodies. Okay, so how many types? We have warm autoimmune hemolytic anemia and cold autoimmune hemolytic anemia. Warm wala agar dekhe is going to be because of warm temperatures, 37 degrees IgG. IgG matlab garam. This is because of IgG antibody which works at 37 degrees and it is going to result in breakage outside. It's an extra, everything is extravascular. I'll tell you what is intravascular, okay? So it is going to be extravascular hemolysis. Example is CLL. Warm autoimmune hemolytic anemia is seen with a leukemia called CLL, which is IgG at 37 degrees centigrade. Cold, on the other hand, the name is only telling me that cold is to do with Ig or what, 4 degree, है ना? Cold is to do with 4 degree. But now you will say, okay, ma'am, IgM होगा नहीं. IgM exactly है और नहीं भी है. Means what? That there are two types of cold autoimmune hemolytic anemias that you have to know. One is the cold agglutinin disease. Break karo. Cold means at 4 degrees. Agglutinin means what? All the red blood cells will agglutinate. So look at this. Can you see all the red blood cells have agglutinated, made clumps? This is cold agglutinin disease. Which antibody is responsible for it? Iske liye to it is IgM. Perfect. IgM going to act at 4 degrees centigrade. But there is another thing that can happen at cold at 4 degrees centigrade, and that is cold hemolysin disease. Hemolysin matlab the RBCs are going to break off. The RBCs are going to break off, and this is also known as PCH. PCH is paroxysmal cold hemoglobinuria. You will say, fine ma'am, this much I've understood ke cold word to you are using. Paroxysmal cold hemoglobinuria, cold word you are using is fine, but please tell me what is paroxysmal, what is weird about it? Because cold hai, it is occurring at 4 degree. At 4 degree I expect which antibody to work? IgM. I expect IgM to work. G was garam, that was working at 37. At cold, IgM is working. But the weird thing over here is, this is going to be mediated by IgG. So imagine IgG ne dhokha diya. IgG was supposed to be garam. It was supposed to work at 37 degree. Suddenly it has started coming. It has not followed the mass bunk. It is not with the other students of the class. Wo alag se topper hai who is going different. So this IgG has been given a different name. Like Chatur was the person in 3 Idiots, na, whom everyone used to call as Chatur, separate person in the class. Same way over here. So we have IgG who's not following the rules. It is not working at 37 degree. It has started working at 4 degree centigrade. That is why this has been given a pet name, and that is Doneth-Landsteiner antibody. This IgG is known as the Doneth-Landsteiner antibody. So now I want to summarize this for you. Autoimmune hemolytic anemia, if they say at 37 degrees matlab garam, no problem, IgG is the one, this is associated with CLL. If they say cold, you will say cold to will remain 4 degree, but cold can either be because of IgM causing cold agglutinin disease, everything will agglutinate, or it can be IgG, the pet name Doneth-Landsteiner antibody, which has started working at 4 degree, causing cold hemolysin, everything will break, and that is paroxysmal cold hemoglobinuria. Please note, all of them are extravascular hemolysis. Matlab, if I have to make a summary, this is warm autoimmune hemolytic anemia is extravascular hemolysis. Cold agglutinin disease is also extravascular hemolysis, but this paroxysmal cold hemoglobinuria is intravascular hemolysis. And I have actually come to a conclusion. Before I end, almost everything was extravascular hemolysis. Hereditary spherocytosis tha, ya fir for example sickle cell anemias tha, ya thalassemias tha, everything was having extravascular hemolysis. But when I'm talking about intravascular hemolysis, the P's and the P's were coming. Paroxysmal nocturnal hemoglobinuria was coming over here. Paroxysmal cold hemoglobinuria was also coming over here. So P and P was coming in the intravascular. Also one more thing, there is something which was coming in both, and that both wala thing was G6PD. G6PD deficiency was showing you both. So I hope this can help you in differentiating extravascular and intravascular. Just a quick recap, jo P and P hai, they are the ones which are primarily coming under intravascular hemolysis. Okay, rest all of them were extravascular, and G6PD was both intra and extravascular. Yes, on that note, finally, we are done with this. The next part of hematology that we'll be starting with are the white blood cells. And under this, the first slide that I have for all of you is the most important picture that you guys get. The pictures of the white blood cells, but first you need to know the order. So starting from the maximum to the least, if I go in that particular sequence, we have a mnemonic which says never let monkeys eat bananas. So going by it again, so you can see as I'll be writing never for neutrophil, let for lymphocyte, monkeys for monocyte, eat for eosinophils, and bananas for basophils. So never let monkeys eat bananas is how you learn it. So how do they look like is also you need to know that picture as well is very important. No? So the first is a neutrophil. A neutrophil is something that is going to have 3 to 5 lobes. You can see 1, 2, 3. That is a neutrophil. Lymphocyte is simple looking round cell, simple looking nucleus. There's nothing to worry about it. Next is a monocyte. In a monocyte, all of you can visualize it has a kidney-shaped nucleus. If you look at the nucleus out here, it's looking like a bean or a kidney. So monocyte is a kidney-shaped nucleus. Coming to eosinophil, this is the only cell in this series which is looking very, very orange, first point. So it's an orange looking cell, and apart from orange looking, it's also, look at the nucleus. The nucleus looks as if someone's wearing spectacles. It's got a spectacle shaped nucleus. And finally, B for B, when I'm talking about the basophils, basophils are extremely blue-black. Look at the granules are very, very blue-black. In fact, they ask you a question, what is the special stain for basophils? For these basophils, what is the special stain? So whether they ask you for basophils or they ask you for mast cells, the special stain is going to be the same, and that is toluidine blue. So you can see all these have become positive with toluidine blue. So never let monkeys eat bananas. That aspect of the WBCs is done. Now we'll start with the disorders. Of course, the first disorder that we are going to study is leukemias, then lymphomas, and then plasma cell disorders. Starting with leukemias, my first leukemia in front of us is going to be the acute lymphoblastic leukemia. So before I start with all of this, can you tell me what is the definition of an acute leukemia or any acute leukemia for that matter? Acute word basically refers for more than 20% blasts. Remember, more than 20% cutoff has to be met if I'm dealing with some kind of an acute leukemia. So acute lymphoblastic leukemia means I'm going to have lots and lots of lymphoblasts in it. So before I start off with the leukemias, I feel it is very important you know all the blasts also, all the blasts and the stains, so that full story is done, and in the end I just have to fill in the blanks. So we have lymphoblast and myeloblast to begin with. How do I differentiate between them? Which of them is going to show you the presence of OR rods? I think everyone knows. Myeloblast shows you the presence of these rods, which are known as the OR rods. So OR rods are going to be seen with the myeloblast. Sounds well. Now, what are they positive for? They are positive for myeloperoxidase. Common sense, na? Myeloblast, myeloperoxidase. They are common. They are positive for Sudan black B, and they are positive for chloroacetate esterase. They are positive for chloroacetate esterase. So repeating the three tests, myeloperoxidase or all three-letter things, MPO, SBB, Sudan black B, CAE, chloroacetate esterase. What about lymphoblast? Lymphoblast, as I can see, is pink color ka blocks. Lymphoblast is going to be pink color ka block. So pink for pass and block for block positivity. So lymphoblast shows you pink color ka pass block positivity. But if examiner particularly asks you what about the T lymphoblasts, remember T lymphoblasts are acid phosphatase positive. T lymphoblasts are acid phosphatase positive. So myeloblast and lymphoblast done. There's one more blast, guys, that we have, and that is monoblast. Please note the way you write monoblast, I'll write it for you. Monoblast is how you're going to learn it. Why am I saying monoblast? Because monoblast shows you NSC positive. What is NSC? NSC is non-specific esterase. NSC is non-specific esterase. So basically exam mein confusion hota hai. Chloroacetate esterase is for myeloblast and non-specific esterase is for monoblast, and you get confused between these two esterases. Now you won't, because non-specific will remind you of monoblast. It will remind you of monoblast, and chloroacetate esterase will remind you of myeloblast. So your stains are done. Coming back, what am I talking about? I'm talking about acute lymphoblastic leukemia. How many? Acute leukemia matlab how many blasts? More than 20% blasts. And if I'm saying lymphoblast, do we all know that they are going to be pass positive? Wo sab pad liya. Now let's do the classification. There's a FAB classification which says that the most common ALL is ALL L1, and that has the best prognosis. Then they say there is L1, L2, L3, out of which, please note, ALL L3 is the least common and has the worst prognosis. So God has been kind. Whatever is most common is good for the patients. Whatever is least common is bad for the patients. Please note, out of these, it is ALL L3 which is oil red O positive. When I say something is oil red O positive, matlab it has fat, na? So you can see these white holes. These white holes that you're seeing in these blasts, or in other words, you're saying they show you vacuolations. So they ask you, which is the leukemia that shows you vacuolations? ALL L3 shows you vacuolations and oil red O positivity. Very, very important question. PYQ. ALL L3 is going to show you fat, oil red O positivity. What is the WHO classification? WHO says, no, I am not interested in this L1, L2 thing. WHO says either it is BALL or it is TALL. And please note, it is the TALL which is going to be going into the tissues. So the tissue infiltration is going to be seen by the TALL. And what tissues am I talking about? It can go into the brain, it can go into the mediastinum, and it can go into the testes. So testes mein jayega, matlab it's bad, na? Cancer is going to brain or mediastinum or testes. It's a bad thing. So which gender is going to have a poor prognosis? So wherever I make this sad emoji, that means bad prognosis. So males ke liye automatically poor ho gaya, right? Because it's going into the testes. So remember, B in ALL and TALL, and T is T for T. TALL is the one that is going to go into the tissues. What about the genetics? I have written these tend to show you hyperdiploidy. So diploid क्या है? Diploid is 2n. Hyper is more than 2n. So मतलब 3n, 4n and so on. Trisomy of chromosome 4, 4 plus 3, 7, 7 plus 3, 10. And translocation 1, 2, 2, 1. What have I tried to make over here? देखो, hyperdiploidy I said more than 2 मतलब 3. Trisomy anyway means 3. Chromosome 4, 4 plus 3, 7 plus 3, 10. And translocation 1, 2. 1 plus 2 is 3. 2, 1. 2 plus 1 is also 3. So anywhere the 3, 3 number is going to come, that genetics is going to carry a good prognosis for the patient. All the three, hyperdiploidy, translocation 1, 2, 2, 1, trisomies, they are all good. Whereas hypodiploidy or translocation 9, 22, all of these are going to carry a bad prognosis for ALL. And let me tell you, the most common genetic problem that you see in ALL is hyperdiploidy, and the good one. That is your one-stop solution to the entire ALL. Remember, ALL is acute. Every acute leukemia has more than 20% blast. Which blast? Lymphoblast. Lymphoblast ka characteristic? We have already done. It is going to show you which positivity? Past positivity. How many classifications? FAB says L1, L2, L3. L1 is most common and good. L3 is least common and bad. L3 is also very, very fat. That is oil red O. Very fatty, very oily, very oil red O positive. What is WHO? WHO is BALL and TALL. T for T. TALL is the one that is going into the tissues. One in the brain. Second is the mediastinum. Third is testes in boys. Therefore, boys have a bad prognosis. All the three number things are going to be good. Hyperdiploidy, trisomies and translocation 1, 2, 2, 1. Other things are going to be bad. So ALL is sorted. Obviously, that means now I'm going on to the next one. And the next one stands for acute myeloid leukemia. That is AML. Please note, here also there is going to be a FAB classification. But that FAB classification goes all the way from M0 to M7. That is the FAB classification that I'm going to follow. So let's start. AML M0. 0 matlab anda. Anda means undifferentiated. It is AML undifferentiated. This is the, because when I'm saying AML, automatically you guys have started thinking कि अच्छा acute है. Acute matlab ma'am will say the same story कि blast count is going to be above 20. And myeloid है तो it must be myeloblast. Matlab now we are dealing with this story. Myeloblast or rod wala story. Matlab all of them are going to be positive for MPO and all. But when I'm saying anda matlab anda, it is MPO negative also. It has nothing to do with MPO. Okay, anda means 0. Okay. Coming to M1 and M2. See, M1 is younger brother, chota number. M2 is older brother. So younger brother will not have any maturity. Older brother will have maturity. Simple way of learning. M1 is without maturation. M2 is going to be with maturation. Let me tell you, M2 is the most common AML that you have, and it is associated with translocation 821. I'm telling you some translocations which are going to be very important. So M0, M1, M2 ho gaya. Now coming to M3. M3 is known as APML. Acute promyelocytic leukemia, and this I'm going to take up on a separate slide because every word about it is important. So सबसे पहले acute promyelocytic leukemia is going to show you translocation 1517. How did I learn it? It is AML M3. So 3 ka 15, 3 5s are 15. It shows you translocation 1517, and that means there is going to be a fusion of PML RARA gene. There is a PML RARA fusion that is going to occur. देखो APML में obviously PML RARA fusion ही होगा. That is point number 1, or you can say question number 1. Question number 2. This is the only leukemia which is associated with DIC, and this is a recent FMG and a recent NEET PG question. The only leukemia associated with DIC is APML. Coming to question number 3, what is going to be the cells that you'll find? What is the microscopic examination going to show you? So rather than writing question 3 here, I can safely write question 3 here. The cells that you see are Faggot cells. What are Faggot cells? Look at these OR rods. There are so many OR rods and they're all as a crisscross. So what are Faggot cells? They are nothing but the crisscross of the OR rods. Sorted? Next, what is question number 4? Question number 4 tells you that what is the treatment aspect. So for the treatment, guys, please remember, we are going to give these patients not chemotherapy. We are going to give these patients all trans retinoic acid. What did I say? Dobara bolo, all trans retinoic acid means I am dealing with vitamin A. They ask you, which is the leukemia which is treated with a derivative of vitamin A? It is AML M3. And other than that, along with this, I also club it with arsenic trioxide. I also club it with arsenic trioxide. So repeating, like I said, for AML M3, translocation, so we'll write translocation is 15, 17, but this is the only leukemia which is associated with DIC. This is the only leukemia which I'm going to treat with all trans retinoic acid, vitamin A. Now coming to M4, अब M4 and M5 में suddenly you realize mono word has started coming, monoblasts have come. So 4 को तो I have learned, 2 का स्क्वायर क्या है 4, 4 का स्क्वायर क्या है 16 है ना, 2 4 16 means if someone asks you what is 2, I will say दोनों blasts. Myeloblast is also there, monoblast is also there, दोनों blasts. 2 का 4 square 4, so M4, and now if they ask you 4 ka square, that is 16, so this shows you inversion 16. So please remember, I've learnt it as 2 into 2. 2 into 2 matlab myeloblast also, dono blast, myeloblast also, monoblast also. That makes it AML M4, and 4 4s are 16. That is going to make it inversion 16. Whereas when we come to M5, that is only and only monoblastic leukemia. You know what is the problem with mono? Mono matlab it's going to go into the tissues. So please remember, both M4 and M5 are responsible for tissue infiltration. This is a question that you get. So if they say there's something that has gone into the gums, or there is something that has gone into the skin, it is tissue infiltration which is going to happen. Coming to M6, what is M6? It is pure erythroid leukemia, and M7 is megakaryoblast leukemia, which is seen in people with Down syndrome में who are less than 3 years of age. They show you AML M7. So this is your summary that you had. What are the 3 main translocations I told you? For M2, 2 ka multiple 8, so 8 21. M3, 3 ka multiple 15, so 15 17. M4, 4 4s are 16. These 3 are very, very important translocations that you have. So that was about AML. Now something that is important for the NEET PG and INI students, not for FMG. FMG students can skip this slide. That is going to be what are the different stains. You've all read it. I'm just going to summarize it. There's PAS, myeloperoxidate, chloroacetate esterase, and non-specific esterase. Firstly, PAS. PAS you said, ma'am, PAS to lymphoblast mein tha. Bilkul, lymphoblast to correct. That dot positivity, block positivity. But where in AMLs is PAS there? So the pink wala PAS hai. M3, M6 and M7, 3, 6 and 7, M3, 6 and 7 are also PAS positive. PAS ho gaya. Anda wala to I have written in one side because anda is 0, na, nothing, no stain is going to come positive. So usko bhul jao. Rest all of them, see wherever you are seeing myeloblast ka stains kya hai? You will see myeloperoxidase and chloroacetate esterase. Myeloperoxidase and chloroacetate esterase will be seen wherever you see myeloblasts. Where do you see monoblast? Monoblast are seen in M4 and M5. Monoblast ke liye monoblast, non-specific esterase, non-specific esterase. How simple is that? You had nothing to do. You just had to learn PAS wale kaun se hai? 3, 6 and 7. Cut them off. 0 ko cut off kar do because that is anda, that is not going to show you anything. Rest all of them show you myeloblast. So myeloblast ke markers dale. And which are the ones that show you monoblast? M4 and M5. So monoblast ka markers you put there. So the question that you will get is, which of these is going to be double esterase positive? Which of these is double esterase? Means it shows you dono esterase, dono blasts, dono esterase. So double esterase positivity is noted in a case of AML M4. How simple. That is the question that we expect over here. I hope everyone's okay with AML so that I can go on to the chronic leukemias. Now when I come to chronic, finally blast count will not be more than 20%. Remember that? Now remember chronic lymphocytic leukemia. When we say chronic lymphocytic leukemia, it's quite different. It is the only one which shows you deletion 13q. It is the only one which is not associated with radiation. Rest all the leukemias are associated with radiation. This is not associated with radiation. So how will I do the diagnosis? Chronic lymphocytic, lots and lots of lymphocytes. Let me show you a picture first. Lots and lots of lymphocytes, not just lymphocytes. Those lymphocytes will break off. What is that condition known as? That is known as smudge cells. NEET PG 23 question. Smudge cells, FMG 23, 22, दोनों sessions में आया. Smudge cells are seen in case of CLL, but please remember smudge cells are non-specific. You will not see them only in CLL. They can be seen in a lot of conditions. And please remember, they are not even a part of the criteria. Peripheral smear shows you smudge cells, but they're not a part of the criteria. So what is the criteria, guys? For chronic lymphocytic leukemia, you have to look at lots of lymphocytes. So when I look at the peripheral blood, the blood sample should show you absolute lymphocyte count of more than 5,000. Absolute lymphocyte count of more than 5,000. On a bone marrow, the lymphocytes should be more than 30%. On a bone marrow, the lymphocytes should be more than 30%. And on a flow cytometry, I have learned CLL is sab kuch positive. Sab kuch positive means it is going to be positive for CD5 also, for CD23 also, and for CD200 also. That's a new marker but important. Sab kuch positive, that is CLL. Okay? So both all these criteria have to be there. You take a simple blood sample, 5,000 lymphocytes. You do a bone marrow sample, 30% lymphocytes. And sab kuch CD markers are positive, that is CLL. What will peripheral smear show you? It will show you smudge cells. In fact, please remember, you will say, ma'am, you are obsessed with lymphocyte word over here. Our ears are bleeding. So many times you have said lymphocyte. You're not using any other cell. No myeloblast, no blast, no neutrophil, nothing. But lymphocyte. Exactly. Because you see only one uniform. This is known as convent schoolgirl appearance. Everyone is wearing the same uniform, that is lymphocyte. Convent school. So he called it convent schoolgirl appearance. Now coming back, what are the syndromes that can be associated? If CLL is associated with autoimmune hemolytic anemia and immune thrombocytopenia. You will say, ma'am, ye to pura bone marrow effect ho gaya. So basically, when everyone is affected, that is how I have learnt it. When everyone is affected, everyone matlab even means RBC is affected, WBC is affected, platelet is affected. Kaise? RBC is showing me autoimmune hemolytic anemia, WBC is showing me CLL, and platelet is showing me ITP. Everyone is affected, that is Evan syndrome. What is Richter's syndrome? Rich hona. Rich, you will say, rich means ma'am bada aadmi banna. Bada aadmi means what? Diffuse large B cell lymphoma, large, big. So from a small person means from a small lymphoma, if it changes into a large lymphoma, from a small person it becomes a big person, means it's become rich. What is Richter's syndrome? When CLL, SLL, small lymphoma changes into a large lymphoma, bada aadmi banna, that is rich hona, Richter's syndrome. So remember these two syndromes which are associated with CLL. CLL, convent schoolgirl appearance, seems to be sorted. Now I move on to the last leukemia, and that is going to be CML. We all know CML stands for chronic myeloid leukemia. Now, when I say chronic myeloid leukemia, we have the genetics which is known and ruttoed by everyone. Translocation 922. 922 means the fusion of what? It is BCR-ABL fusion. And what is that fancy name that has been given to it? This is known as the Philadelphia chromosome. This I don't think you need to revise. Everyone knows. But you know what happens because of this? Because of BCR-ABL fusion, what happens, guys? There is an increase in tyrosine kinase levels. So what do you think will be your treatment? You will give tyrosine kinase inhibitor. Name a tyrosine kinase inhibitor. Imatinib. Imatinib is a tyrosine kinase inhibitor. You've understood why. The genetics says the tyrosine kinase will increase. So the treatment is that I will give a tyrosine kinase inhibitor. What are the clinical features that they will write in the exam? Very, very famous. Listen to it very carefully. Massive splenomegaly will be mentioned. अब देखो, patient will not come to you and say कि अरे I have massive splenomegaly. What will patient say? Spleen इतना बड़ा है ना, तो patient will say something heavy is there in my abdomen. Something is pulling my abdomen down, dragging sensation. That is what my patient is going to come to me and say, that I am having a dragging sensation in my abdomen. Okay, patient doesn't know he has spleen or what. Dragging, something is pulling me down. So, when they talk about CML, up CML mein to, you know, this is not like that convent schoolgirl. There's not only lymphocyte, myeloid, matlab everything of myeloid is seen. Have a look at this picture. You are seeing neutrophils also. You are seeing few eosinophils also. You will see basophils also. You will see all the precursor, bada cells. So, you are having full house party, garden party happening over here. So, please remember, CML shows you garden party, or if you wanted to call it in terms of uniform, so school wala uniform uniform तो नहीं है. Now everyone is dressed differently. How you dress up in college. So this is the college girl appearance. This is the college girl. So for CLL, he had only said all the girls are dressed in the same uniform. Chronic lymphocytic leukemia, lymphocyte. तो सबका same uniform. Convent school girl appearance. CML में there is everyone's wearing different clothes. So that means it is college girl या फिर garden party appearance, right? So coming back, this CML has how many phases? It has CAB phases. CAB phases means chronic phase, accelerated phase, and blast crisis. Chronic phase may remember that the blast count is less than 10%. Accelerated may the blast count is 10 to 19%. And blast crisis means the CML has changed into a leukemia like AML or ALL. Acute ho gaya. Acute means that the blast count has now crossed 20%. When something becomes acute, means the blast count is above 20%. So simple, CAB phase, chronic, accelerated and blast crisis. Chronic ke andar it is less than 10, accelerate thoda speed badhao, accelerate karo 10 to 19, but as soon as you cross 20, you have become acute leukemia. This is blast crisis. Easy to learn, less than 10, 10 to 19 and more than 20, itna easy nahi hai. Accelerated phase has other criteria also. Basophils are also present. I told you na, garden party, lots of cells are there. Basophils are more than 20%. अब exam में ना please सुनना ध्यान से, read very carefully what more than 20% has been put up by the examiner. If examiner says basophils are more than 20%, you are in accelerated phase. If examiner says blasts are more than 20%, you are in blast crisis. So don't just get excited looking at 20%. What 20% is important. Next, please remember if the total leukocyte count is very high, or they say that the platelet count is very high, or they say that the platelet count is very low, dono taraf, very high platelet, very low platelet, or if they say the spleen size is very massive and nothing is responsive to therapy, unresponsive to treatment, which means you are giving imatinib but spleen size is as big, platelet count is either very high or very low, WBC count is very high, matlab nothing response hi nahi dikh raha, you're not seeing any response, that is also a criteria of accelerated phase. So accelerated phase has very lots of things that you have to know. Last thing, please remember lap score. There is something known as a lap score which I want all of you to know. So either you call it lap or you call it NAP, whatever suits you. So basically, first I'll tell you what is L. L stands for leukocyte. L stands for leukocyte and N stands for neutrophil. So same ही चीज है, leukocyte and neutrophil is the same. But what is this AP? That is alkaline phosphatase. So now you've understood that basically by doing this score, I'm trying to find out alkaline phosphatase levels. Please note the normal score is 40 to 100. They shall not give you the normal value. याद करके जाना है. Normal score is going to be 40 to 100. So now you need to know that in a case of CML and PNH, the lap score is low. The lap score is low. You know, students tend to forget. Low matlab less than 40. Students tend to forget CML में low था या high था. तो CML is sounding like small. Small जैसा है ना. तो CML में the lap score is going to be low. Whereas now they will ask you, under which situation is the lap score going to be high? So I have learnt lakes and ponds. What is lakes and ponds that you have to know? L, lakes for leukemoid reaction. Lakes for leukemoid reaction. P for pregnancy. O for OCPs. N for neutrophilia. And DS for Down syndrome. So please remember that lap score, common sense bhi lagao na, you don't need a mnemonic. Lap score is what? Neutrophil alkaline score. So basically, if neutrophil levels will shoot up, the score will also shoot up. तो अब leukemoid reaction में neutrophil count goes high. Pregnancy में you studied in obstetrics, pregnancy में neutrophil is high. OCPs also result in increased neutrophil. Downs में भी neutrophil count increases. Neutrophilia में तो obviously neutrophil count increases. So wherever the neutrophil count will go up, the lap score will already go up. That is known as lakes and ponds. And where is the lap score going to be low? It is a case of CML or PNH. So now I can complete this table. That what is the lap score in CML? CML में small. So the lap score is going to be low, and repeating, the normal lap score is 40 to 100. That is your final chart that you have for the CML, and we've wrapped it up. Leukemias are done. What are we going to start with next? Quickly, in half an hour, we are now going to do all the lymphomas that are important for all of you to know. So I've got you 5 or 6 tables. I know it's tough, but we'll try to wrap it up and we'll try to finish it in as concise a manner as possible. Having discussed the leukemias, now let's go ahead and talk about the lymphomas. Under the lymphomas, we all know, na? Hodgkin's versus non-Hodgkin's. So let's start. Let's start with Hodgkin's lymphoma, and we divide Hodgkin's lymphoma into 2 types. There is a classical Hodgkin's lymphoma and a non-classical Hodgkin's lymphoma. So exactly in these 2 slides, your Hodgkin's is finished. When I'm talking about Hodgkin's lymphoma, तो क्या reason था? Why did we divide it into classical versus non-classical? Because all the classical ones, as you will see, they are going to be affiliated with Epstein-Barr virus. All the classical ones are going to be Epstein-Barr virus affiliated, whereas the non-classical one is not, no Epstein-Barr virus association. First point. Okay? Second, another difference that you saw between classical and non-classical was both of them were showing Reed-Sternberg cells, but the classical ones had CD15, 30 and PAX5 positive. I hope everyone remembers this is what a classical Reed-Sternberg cell looks like, the famous owl eye appearance. And what are the markers that I'm telling you? I'm telling you CD15, CD30 and PAX5. I hope you remember this. We've done this earlier, that CD30 happens to be the most sensitive and PAX5 is going to be the most specific. PAX5 is going to be the most specific. I hope everyone remembers this. So coming back, the classical one has 2 reasons. One, it is CD15, 30 and PAX5, and second, it is Epstein-Barr virus. Whereas when I go to the non-classical has no association with EBV, and that 1530 story is also not there. It has a different set of markers. What are those set of markers? It is 2045, almost double. Pehle 1530 tha, now it's 2045. 2045, EMA and BCL6. Little bit ratta that you'll have to do. 1530 pehle tha, classical ones were 1530. Now it's going to be 2045, EMA and BCL6. So you've understood the reason of dividing them into 2 variants. Now we'll start with the details. Under the classical, repeating, classical one has EBV association, has 1530 PAX5 and it has 4 varieties. The most common in the world is nodular sclerosis. And the most common in India, MI, that is mixed cellularity. Now, you will also have to know there is something called, which is very, very rich in lymphocytes and which is very, very less in lymphocytes. So, lymphocyte rich, lymphocyte depleted, ho gaya 4 types. Nodular sclerosis in the world, MI for mixed cellularity, most common in India. Very, very rich in lymphocyte, very, very poor in lymphocyte. What are going to be the RS cells that you see? Nodular shows you lacunar. Rhyming ho gaya? Nodular sclerosis is going to show you lacunar cells. This is how lacunar cells look like. You will see there is an owl eye, and around that owl eye I can visualize that there is a white space. Owl eye ke aspas there is a whitish space that is present. This means this is a case of lacunar RS cell. Lacunar is seen in nodular, so it is nodular sclerosis. The mixed cellularity, the one that you see in India mein normal dikhta hai. Wo classical owl eye thing is seen in India. The classical owl eye is seen in India, and remember, not only is this most common in India, but this is the most commonly seen with EBV and with HIV. If they say there's an HIV positive person and he has ended up having Hodgkin's lymphoma, to kaun sa Hodgkin's lymphoma hoga? Mixed cellularity. So with EBV and with HIV, it is always mixed cellularity. India may be sabse common classical RS cell is seen. Lymphocyte rich. It shows you mononuclear RS cell. What is the meaning? See, when I was saying RS cell has owl eyes matlab 2 na, so it had 2 nuclei. Now I'm saying that the mononuclear RS cell ka matlab it is going to have only one nucleus. So I have learned lymphocyte rich. He was only running after money. He's become so rich, but he's not paid any attention to his family and friends. He's left single in life. Take a very brutal way. So he's running after money. He's not had any relationship. He's single, mononuclear RS cell. Coming to the last one, lymphocyte depleted. It is sounding so dead. So it has a dead RS cell. It has a mummified, mummy wala RS cell. So the mummified RS cell is the dead RS cell which is seen in depleted. So now tell me which of these is sounding that it will be associated with HIV. This is immunodeficiency associated. Yes, that is why it's so dead. Immunodeficiency could be HIV, could be any other immunosuppressant drug, but that is why it is sounding so dead and so mummified, because it is immunodeficiency associated. So now tell me, in this table, if I ask you the prognosis, What is your answer going to be? It's very, very obvious that the dead wala is going to have the worst prognosis. But in this table, the nodular one has the best prognosis. Only in this classical variety, I'm telling you. Quick revision. Nodular shows you lacunar, most common in the world. Mixed cellularity shows you classical aula is most common in India, most common with EBV, most common with HIV. Lymphocyte rich and single, so mononuclear. Lymphocyte depleted and dead, so it is going to have mummified RS cell and very, very bad prognosis. Okay, now we come to the non-classical. Non-classical matlab no EBV, no 1530. It had 2045 EMA and BCL6 positive. So what is it? There's only one in it, NLPHL. What is NLPHL? That is nodular lymphocyte predominant Hodgkin's lymphoma, NLPHL, and that shows you the tasty popcorn or LNH-RS cell. I'll show you one popcorn. Can you all see? This RS cell is looking like a popcorn. So as soon as they say the word popcorn, it is seen in nodular lymphocyte predominant Hodgkin's lymphoma. ये जो weird सा लंबा सा नाम है. So this is the non-classical one. And it's sounding so tasty ना. Popcorn cell word is only sounding so tasty. तो prognosis तो अच्छा ही होगा. Prognosis will be good. So overall, if the best prognosis is asked, examiner says, I am not bothered about classical, non-classical. ये अपना story अपने पास रखो. I am not interested. Just tell me overall what is the most common or what is the best prognosis. Overall, popcorn are the most tasty. So the best prognosis is for the popcorn. But if the examiner says, nahi, I am interested that in this table, in classical, tell me which is the best, you will say nodular is the best. So basically I realized dono nodular. Students have learnt it as noodles are tasty. Noodles are tasty matlab ये वाला nodular, tasty मतलब good ना, so ये वाला nodular is also good, and जो next वाला nodular है, that is NLPHL, that is also good. So noodles are always good, but which is even better, best noodles कौन सा है? Popcorn वाला noodles best है. So nodular lymphocyte predominant, वो popcorn वाला, that is very tasty and that is the best. Everyone's good with it. You've done all the different type of RS cells and you are finished with Hodgkin's lymphoma, which means that we're going to go on to non-Hodgkin's lymphoma. Under non-Hodgkin's lymphoma, we know this is the one where students give up. B non-Hodgkin's lymphoma and T non-Hodgkin's lymphoma. So now let's begin with non-Hodgkin's lymphoma. I know this is where most of you give out hope and you don't really wish to study, so I've decided to make 2-3 tables and wrap it up. There's a B non-Hodgkin's lymphoma and a T non-Hodgkin's lymphoma. 7 B NHLs, 2 T NHLs, so 9 NHLs in total in a tabular manner we'll do. But before I begin, finish off all their chromosomal abnormalities. So remember, as soon as they write something to do with chromosome number 8, and 8 ke saath some even number is given. So for example, translocation 8 with 22, translocation 8 with 14, translocation 2 with 8. So as soon as some 8 and some even number is given, you are dealing with 8 की तरह क्या लगता है? 8 looks like a B ना, B looks like an 8. So you are dealing with Burkitt's lymphoma. You are dealing with Burkitt. So what is the translocation for Burkitt's lymphoma? Some 8 and some even number. ठीक है? Now we look at the others, 11, 14 and 18. When you club 14 and 18, मतलब translocation 14 teenager and translocation 18 teenager, दोनों teenagers best of friends. Which is the most friendly lymphoma? The follicular lymphoma is friendly lymphoma. It has the best prognosis. Follicular lymphoma, best prognosis. ठीक है? Then take up the two at the margins. Margin वाला क्या है? So translocation 11 and translocation 18. One is margins of age. One is just entering puberty 11 years. One is entering adulthood 18 years. दोनों margins वाला age groups you pick up. This is marginal zone lymphoma. How easy. Coming to the last one, pick up 11 and pick up 14. Translocation 11 and 14, and that is going to be mantle cell lymphoma. That is going to be mantle cell lymphoma. So remember, mantle has that end में EL ना, so 11 is going to be quite important. Not only that, mantle cell के साथ you also have to know that mantle, mental, dumb. Do you remember we did this in neoplasia chapter? Mantle, mental, dumb, it is cyclin D1 positive and एक और 11 है. 11 तो 14 chromosome हो गया. One more 11, it is SOX11 positive. You don't have to do the tables. Trust me, you do this slide and you are done with half of the lymphomas. Let's do a repeat. You take 14, 18 friendly lymphoma. You take the puberty and the adulthood margins of the age, you're done with marginal zone lymphoma. You take 11 and 14, that is mantle cell. Mantle cell is another 11, that is SOX11, and mantle, mental, dumb. तो कौन सा वाला cyclin D? Dumb वाला cyclin D1 positive. After this, one more table you have to do. How do you know the status of these three markers? CD5, CD23, and I'll tell you CD200 also, which is sab kuch positive. So remember, CLL, SLL says sab kuch. The name only has it, na? CLL, SLL, sab kuch positive. Marginal zone lymphoma says margin, neglect the margin, margin pe rehne do, neglect it. So it's everything negative. And mantle cell only 5 positive. Mantle is only 5 positive. Easy. CLL, SLL सब कुछ positive, margin को neglect करो, everything negative, and mantle cell is going to be only 5 positive. Now I'm going to start off with this table because life is going to be very simple. Tell me guys, what is it about follicular lymphoma? Can you tell me? Teenager था तो translocation 14 and 18 and friendly था तो best lymphoma, खत्म. Next one is DLBCL. The name is only quite deadly. Diffuse large B cell lymphoma. Diffuse large B cell lymphoma. The name is only telling me it's diffuse and large, so the prognosis is very bad. But unfortunately, this is the most common NHL worldwide, but it's very, very bad. Coming to the next, let's study about these three first. CLL, SLL, remember, sab kuch positive, 5, 23 for that matter. I can even write the new marker CD200, sab kuch positive, pata hai. Mantle cell, what was the translocation? Mantle, 11 lag raha hai. So tell me, can you write the translocation for me? 11 and 14. What other 11 was there? SOX11 was also there. Mantle, mental, dumb, cyclin D1 positive, and CD markers mein only 5 positive. Next, marginal zone lymphoma, also known as maltoma. Margin, ignore the margin. Everything was negative. 5, 23, 200. Everything is negative. And pick up the margins of age 11 and 18. It is translocation 11 and 18. How easy. What am I left with? I'm left with this Burkitt's lymphoma. But I know Burkitt's lymphoma. Burkitt's was also looking like 8. 8 ke sath even number lagana tha. So I've written over here 8 and 14, 8 and 22, 2 and 8. This is so simple. But the clinical history out here is very important. When they are talking about Burkitt's lymphoma, this celebrity kid is very important for you to know. Please note, they usually give you some child who's belonging to Africa. Because Africa में क्या होता है? Epstein-Barr virus, and Burkitt's is associated with Epstein-Barr virus. So there's an African child and they will give you a jaw swelling. After that, they will show you cells which are showing vacuolations, and vacuolations matlab this is going to be fatty, oil red O positive. And what do you see over here? The very, very famous starry sky appearance. The very famous starry sky appearance. So they also ask you what is stars and what is sky. So jo background hai, the full background out here which I'm calling as the sky. So remember, the sky over here is the Cancer. The sky over here is the Cancer. And what is going to be the stars? The stars over here are the macrophages. So remember, the stars are the macrophages. So actually if they ask you Cancer kya hai, lymphoma kya hai, lymphoma is in the sky, that is the Cancer. The dark background, that is the Cancer. The white stars are innocent macrophages. So Burkitt's lymphoma will be a 10-year-old African child who comes to you with a jaw swelling, who's showing you oil red O positivity and starry sky appearance with a Ki67 of almost 100%. Let me tell you, Ki67 is a proliferation marker. Matlab very, very proliferating, highly dividing. So I think it's okay with everyone. African child, jaw swelling, oil red O positive, starry sky appearance, Ki67 100%. Have we nicely finished this entire table? So I realized na, starting ka translocations kar lo, CD markers kar lo, you are done with lymphomas. So how many lymphomas have we done? 1, 2, 3, 4, 5, 6. How many did I tell you? Under BNHL I told you 7 hoga. To kya bacha? We are left with hairy cell leukemia. Hairy cell leukemia is one of the best stories that we had studied in our full course. What is this? This is a red-haired boy. Why am I calling him red-haired? To pehle to story sun lo. He's a red-haired boy and he loves going to the gym, and anyone who loves going to the gym obviously will keep talking about eggs, that how proteins and eggs are important. He loves buying a lot of branded products like Apple products, MacBooks, so on and so forth. So ये हमारा story है, and obviously this child, you think this person who's only interested in getting his hair colored red, TikTok red boy, na, he's interested in getting his hair colored red, interested in going to the gym, looking and buying expensive products, eating eggs. तो पढ़ाई में तो गोल, पढ़ाई में तो डब्बा, पढ़ाई में तो he's gonna be डब्बा, and he's going to be a brat boy. He's going to be a brat boy. Okay? So if you know this story, why did I call him a boy? Because hairy cell leukemia is more commonly seen in boys. So the boy story is done. Boy pe whatever I'll keep telling, I'll keep tick marking. Okay. And he's a brat boy because this shows you BRAF mutations. Okay. Clinically, what is going to happen? These patients come to you with massive splenomegaly, but do you know which part of the spleen is affected? Now comes the story of the red-haired boy. It is the red pulp of the spleen that is affected. When you do a bone marrow aspirate or a bone marrow biopsy, so this is interesting. Pehle to, why did you do a bone marrow? What did you suspect? So you'll say, ma'am, I suspected that this patient has, I was palpating, he has massive splenomegaly. I said, anything else? You say, ma'am, he's coming with a lot of infections, and those infections are MAC infections, Mycobacterium avium complex. Mycobacterium avium complex, the infections are the MAC infections. I'll say, oh, acha, spleen hai, red pulp, and Mycobacterium avium complex infections hai, let's do a blood test. Blood test pe kuch nahi aaya, cells were very, very less. Cells on the blood test was pancytopenia. I got very worried. I did bone marrow aspirate pe nothing came. I kept taking the suction of the syringe, material only did not come, dry tap. I got more worried. I did a bone marrow biopsy and there I saw the fried egg appearance. This is a question, on which technique do you see fried egg appearance? Have a look at the fried egg, guys. Now you can see all the pictures. Dekho. What are these? These are all the hairy cells. Now I understand why I call it hairy cell leukemia. I can see all these hairy projections. And which microscope am I seeing it on? It's very well seen on phased contrast microscope. So hairy cells are very, very well seen on phased contrast microscope. Then I started seeing the bone marrow, repeating bone marrow aspirate or bone marrow biopsy. This should always remain in your mind. Bone marrow biopsy pe I was seeing the fried egg appearance. I could see those white areas around it. All those white areas are the fried egg appearance. Hai na? So then I said, let me do some markers. So here you go. What are the markers? I can see that annexin A1 is positive. A1 Q? Why not annexin 5? Because when I'm writing hairy cell leukemia, when I'm writing hairy cell, A1 comes in it. AI is coming in it. So obviously I can visualize over here that annexin A1 hoga. And there's another marker positive. That marker is TRAP. TRAP में क्या color आता है? TRAP में ma'am color everywhere is red. If you ask me which part of spleen is affected, red pulp. If you ask me TRAP gives what color? Red color. So if this I tell you is the TRAP stain, so TRAP stain is given what color to the cells? TRAP has given the red color to the cells. So all these are sorted. But now one thing I want to tell for the students who are preparing for the higher institute exams, please note hairy cell leukemia is also positive for CD11C, CD25, CD103 and DBA44. That is why I called him a dabba in padhai, because the new marker is DBA44. And hairy cell leukemia mein kya karoge? The way you draw his face. The way you draw his face, on one side, this face is a goal, hai na? On one, now you have to make his ears. So, okay, let me make one ear over here. It's looking like a 3. And I've basically made his side face. So, side se dekho, so the nose is a 1, then the face is round and the ear is 3. So, 103 ho gaya. Side se dekha, so 103, that is 1. Then I've made 2 hair of his. Hairy cell hai, to hair to dikhega. So, 11 for hairy cell, 103 bhi usse ho gaya. 25 is if you can learn, 25 is not that important. And he's a dabba in padhai, so dabba 44. So remember, just look at the side profile, 103, so CD 103, 2 hair over there, that is CD 11 and dabba 44. This is important for the NEET PG students, okay? So hairy cell leukemia, always think of the TikTok boy. Brat boy, so BRAF, annexin A1 ka mutation, TRAP positivity red color, spleen may be red pulp, infections MacBook Pro, that is MAC infection. Bone marrow biopsy shows you fried egg appearance. The BNHLs are done, guys. Now we are only left with one, and those are the TNHLs. There are 2 TNHLs that you have to know. Anaplastic lymphoma, mycosis fungoides. Anaplastic lymphoma, 1, 2, 3. 3 questions and done. Anaplastic lymphoma, question number 1, this is CD30 positive. Question number 2, it shows you donut cells. Question number 3, ऐसा kidney जैसा hallmark cells. बस खत्म. CD30 positive, it shows you donut cells. It shows you ऐसा kidney वाला hallmark cells. That is anaplastic lymphoma. It's a TNHL. The last one is mycosis fungoides. Fungus infection jaisa lag raha hai. It's not a fungal infection, but fungal infection occurs on the skin, na? So why I call it mycosis fungoides? Because it occurs on the skin. It is a cutaneous TNHL. It is a cancer of the skin, lymphoma of the skin. And can you see these cells in the skin? They are known as Potrier's microabscess. So till the time cancer cells are in the skin, I call it Potrier's microabscess. They decide that we are going out into the blood, and in the blood, can you see what kind of cells are there? They are all making SR brain type of cerebrum, sulci gyri wala. So these are cerebriform cells. These are said to be cerebriform Sézary cells. The day they decide to go into the blood, they are cerebriform Sézary cells, and that is known as Sézary syndrome. That is referred to as Sézary syndrome. So repeating, mycosis fungoides and Sézary syndrome are practically the same thing. Location ka difference hai. Mycosis fungoides is when fungal infection ki tarah. It's not a fungal infection, it looks like a fungal infection. So it's on the skin. And other than skin, if it goes into the blood, I call it Sézary syndrome, but both of them come under the spectrum of TNHLs, and that is all that you had to know. So simple. Now I want to ask you one more question. Is there any other abscess that you guys have studied which could be important for you to know? Have you all studied something called Monro's microabscess? Where have you studied in dermatology Monro's microabscess, and that is psoriasis? So do you remember the mnemonic now? Because I told you Potrier's microabscess is seen in mycosis fungoides and psoriasis shows you Monro's microabscess. Basically, you have to make a combination of P and M. If I ask you P, your answer will be M. If I ask you M, your answer will be P. So PM का combination बनाना है. So if I ask you Potrier's microabscess is seen in which disease? So you'll say P के साथ options are, is it seen in mycosis fungoides or is it seen in psoriasis? So you'll say P के साथ M का combination. So Potrier's microabscess is seen in mycosis fungoides. Next, if I ask you where do you see Monro's microabscess, you'll say okay, P and M का combination. So M के साथ now the disease is going to be psoriasis. So PM is how you're going to go about it. And with that, guys, you will realize that we have finished off all of our NHLs. I know it's a tough thing, but I hope in this quick review you've been able to cover all. Because now the last part that we have to study is going to be the very, very famous plasma cell disorder, and that is multiple myeloma. So jaldi se we have two things, criteria and pictures, and sorted. What is multiple myeloma? What did I say? This is a cancer of the plasma cell. So first, I think it's important that we quickly go and revise what a plasma cell looks like. Plasma cell is going to look like this. Where is the nucleus? The nucleus will always be on the periphery. It's an eccentric nucleus. Nucleus के अंदर जाके देखा तो we saw this ऐसा wheel kind of appearance. The nucleus is going to show me cartwheel chromatin. That is how a plasma cell looks like. And finally, if I ask you that nucleus to theek hai, plasma cell you have understood. Nucleus is on one corner and it shows you cartwheel chromatin. But what around the nucleus? You will see something. This is the most important finding. You will see something known as perinuclear halo. And why is there white ऐसा white area क्यों दिख रहा है? Why is there a perinuclear halo? Because this perinuclear halo contains a lot of Golgi apparatus. Okay, why Golgi apparatus? Because plasma cell has to make antibodies. Proteins, antibodies, kahan banta hai? Golgi apparatus mein banta hai. So God decided that okay, you have to make so many antibodies. I will give you lots of Golgi apparatus. Khatam. 1, 2, 3. It shows you number one eccentric nucleus with a cartwheel chromatin, and it shows you a perinuclear halo. Sorted. The cancer of these plasma cells is multiple myeloma. What is the criteria? The criteria is that the bone marrow plasma cells should be more than 10%. Immunoglobulin, and most commonly which immunoglobulin is there? Most commonly it is IgG. Immunoglobulin should be more than 3 grams. And we should have myeloma defining events. Now you will ask me, what are myeloma defining events? We have CRAB and SLIM. So there is something known as the CRAB criteria and there is something known as a SLIM criteria. So let me quickly analyze. CRAB criteria means calcium levels are more. Why are calcium levels more? Because bone is breaking. There are bony lesions. Which lesions? Lytic lesions, and that is the picture that I've got you. It shows you bony lytic lesions. Next, there is going to be renal insufficiency. Renal insufficiency matlab creatinine बढ़ जाएगा. And lastly, there is anemia. So please remember, calcium, renal disorders, anemia and bony lytic lesions. That is CRAB. What is SLIM? S stands for that your 60, पहले तो we were saying plasma cells are 10% से ज़्यादा, but just in case the plasma cells basically become more than 60%, that is the S, more than 60%. Then we have light chains, Li for light chains, because antibodies mein what is going to be more? Light chains involved should be more. So light chains involved should be more than 100. That is important. And lastly, MRI is going to show you a focal lesion. At least one lesion should be seen which is measuring more than 5 mm. MRI pe at least one lesion is noted. So repeating, there is a Crab criteria, calcium, renal, anemia, bone. There is a Slim criteria, that is 60% plasma cells, light chains are more, and MRI is showing you lesions. That is what you define as multiple myeloma. So ये सब था. This Slim and Crab are myeloma defining events. उसके अलावा immunoglobulin more than how much? 3 grams. Plasma cells more than how much? 10%. Now do you want to look at their pictures? When you're dealing with multiple myeloma, what does the red blood cell show you? It shows you this stack of coins. It shows you the stack of coins, and that is known as the Roulet formation. That is referred to as Roulet formation. Very, very important. It's, as I said, stack of coins. Next, when I look at the plasma cells, it shows me these kind of bodies. Where are these bodies? They are in the cytoplasm. Intracytoplasmic bodies. Okay. So you will say, ma'am, are they seen in the nucleus also? Yes. You can see it over here. There are intranuclear bodies. Intranuclear bodies. Are there any names given to it? Intracytoplasmic bodies are known as the Russell bodies, and intranuclear bodies are referred to as the Dutcher bodies. And how do I learn it for the exam? तो देखो Russell में वो S वाला sound है तो cytoplasmic, intracytoplasmic are Russell and intranuclear are Dutcher. But when I see bodies all around, they started looking like a mulberry. When there are bodies all around, that is known as a mulberry or a Mott cell. Finally, I have a cell which is on fire, a cell which is flaming like this. So that is said to be the flame cell. So if you ask me, what are all these made up of? What are these things in the cytoplasm over here? What are these things in the nucleus over here? What are these so many dots like a mulberry? And what is it that is making the flaming? Common sense. If it is a cancer of the plasma cell and it is making lots of antibodies, तो सबका composition is antibodies. Whether Russell or Dutcher or mulberry or flame, composition is going to be antibodies. And all of these were bone marrow aspirate finding, because in the exam you get confused when examiner gives you the pink and blue, that is bone marrow biopsy finding. वही तो दिख रहा है. Aren't you seeing the same plasma cells? How do I identify plasma cells? Nucleus कहाँ होगा? कोने में. Periphery में nucleus है with a white area around it. Again over here, periphery में nucleus, white area around it. All of them have nuclei which are shifted on the side. So these are nothing but sheets and sheets of plasma cells. These are sheets of plasma cells. You will say, ma'am, very good. Plasma cell dekh liya. One part of the criteria is done. I have understood. Counted plasma cells done. How will you prove antibodies? What test are you doing for antibodies? I am doing an electrophoresis. I am going to go ahead with an electrophoresis. And what do we see on an electrophoresis? We see the very, very famous M spike. We see the presence of M spike. That shows you what? Dekho. Normally, if I tell you normally remember my hand. Ye jo first, I am looking at the blood. If I look at your normal blood sample, maximum you will have is albumin. Look at the blue color tracing, guys. The maximum that you will have is going to be the albumin. So this peak over here is albumin. Then you have 3 fingers, na? 1, 2, 3. You have alpha 1, then you have alpha 2, and then you have beta. So remember, the normal point is that the maximum protein in the blood is albumin, then alpha 1 protein, alpha 2 protein, beta protein, and एक ऐसा छोटा सा mountain आता है. That छोटा सा mountain is the gamma proteins. Gamma मतलब immunoglobulins. Gamma basically means immunoglobulins. But can you see what has happened in multiple myeloma? The yellow color tracing. Albumin is the same, alpha 1, alpha 2, beta is the same, but what happened in the gamma level? Can you see this peak that has suddenly come up in the gamma level? Yes, everyone can visualize this gamma peak. This is known as the M spike. This is the M spike. Remember, M matlab myeloma ya monoclonal. It is not IgM. It doesn't mean it is IgM. This is the myeloma or the monoclonal spike. But which is the most common antibody? Again, I'm telling you, the most common antibody is IgG. M se ye mat yaad karna that IgM is more common. No, IgG is still more common. Reason for calling it M is myeloma or monoclonal spike. So this is also done. But before I end this, Whatever I was saying was, plasma cells were where? I was showing you plasma cells either on bone marrow aspirate or on a bone marrow biopsy. Matlab bone marrow mein. You will say this means peripheral smear has no plasma cells. Exactly, it doesn't. If the peripheral blood starts showing you plasma cells, if the peripheral blood starts showing you more than 20% plasma cells, this is known as a case of plasma cell leukemia. देखो जैसे acute leukemia में what was the blast count? Acute leukemia में blast count was more than 20%. तो यहाँ पे if the plasma cells become more than 20%, then it is a plasma cell leukemia. ठीक है? So in multiple myeloma, everywhere I'm talking about plasma cells in the bone marrow, but when it is in the peripheral blood, it is a plasma cell leukemia. On that note, I want to quickly finish off the markers also of the plasma cell. Remember कि जो हमारे normal plasma cells होते हैं, they are everything positive. Means they are going to show me the presence of CD45, CD19, CD38, CD138 and antibodies. Malignant plasma cells are only 38, 138 and antibody positive. They are not 45 and 19 positive. How am I going to learn this? If you remember the story of the good child and the bad child. So remember, plasma cells are what? Can you just quickly tell me? Plasma cells are coming from what? Plasma cells are coming from the B cells, and B cells are nothing but white blood cells. Normal plasma cell. Every white blood cell on this planet is CD45 positive. Neutrophil, lymphocyte, monocyte, eosinophil, basophil, plasma cell. कोई भी white blood cell होगा, that is going to be 45 positive. Out of that, if they are B cells are definitely CD19 positive. Plasma cells ka markers are 38 and 138 and those are also positive. Normal plasma cell is positive, but cancerous plasma cell, cancer is a bad child, na? Cancer says, I am not going to show the markers of my parents. Parental markers kaun se the? Parental markers were CD45 and CD19. Bad child says, I am not going to take care of my parents. I will not show CD45 and CD19. I am only going to show my own markers. I am only going to show 38, 138. So repeating, WBC ka marker CD45, B cell ka marker CD19 and plasma cell ka marker 38, 138. So a normal plasma cell is a good boy, a good child. He's taking care of his parents also. He's taking care of himself also. So everything positive. But cancer matlab bad boy. He has forgotten his parents. He has forgotten the 45 and 19, only focusing on himself, 38, 138. And that is what you have in a malignant plasma cell. Okay with everyone? Because on that note, we have almost finished this with one last thing. Everywhere I was saying IgG is most common, IgG is most common, because now I want to tell you there is something called Waldenstrom's macroglobulinemia, and macroglobulin tells me that IgM is going to be elevated. And whenever IgM is going to be elevated, there is going to be hyperviscosity syndrome that shall occur. Hyperviscous matlab hemorrhages, headaches, vision problem. Hyperviscosity occurs with IgM. It is Waldenstrom's macroglobulinemia, known as lymphoplasmacytic lymphoma. It is LPL. It is lymphoplasmacytic lymphoma. So if someone asks you कौन सा cell दिखेगा, lympho and plasma, बहुत common sense के साथ, you will say I will see presence of lymphocytes, I will see presence of plasma cells. So you think the examiner is dumb that he's going to ask you this question? नहीं, he will ask you what else. What else में M for mast cells. देखो इसमें सब कुछ MM चलेगा. Waldenstrom's macroglobulinemia is showing you what? IgM. Which extra cell is it showing you other than lymphocytes and plasma cells? Of course, mast cells. And what is the genetics? That is also M. It shows you MYD88 mutation. It shows you the presence of MYD88 mutation. So repeat, macroglobulinemia shows you IgM, shows you mast cell, shows you MYD88 mutation, and it shows you clinically the hyperviscosity syndrome. This is what you need to know with IgM. I hope this is clear to everyone. Everyone's settled with all of this, and that wraps up our WBC chapter as well. Now let's begin with the platelet and the bleeding disorders. So first, when I start with platelet, I think I first want to introduce you to the precursor of platelet, the mother of platelets, and that is megakaryocyte. Platelet comes from a megakaryocyte. You can see it's got a lot of nuclei. It's a multinucleated cell. But now in the exam, they're not going to ask you normal megakaryocyte. They will ask you the changes stages of megakaryocyte that I have shown you out here. So please note a staghorn megakaryocyte. What is staghorn? You can see that the nuclei are in the shape of the horns of a stag or a deer. Staghorn megakaryocyte is seen in ET. What is ET? Essential thrombocythemia. Staghorn megakaryocyte is seen in essential thrombocythemia. Coming to the next, what is this? Megakaryocyte just has 3 nuclei, just like the pawn ball. ये वो shop होता है, there's a shop where you give your gold and you get money. That shop is known as a pawn ball. Uska symbol is the 3 balls. So when you start seeing these 3 balls, 3 nuclei, that is a pawn ball megakaryocyte, which you see in a 3 alphabet disorder, that is myelodysplastic syndrome. Next, you see cloud-like megakaryocyte. The nuclei are present like a cloud. That is seen in primary myelofibrosis. That is seen in primary myelofibrosis. And finally, you're seeing a megakaryocyte which is looking like a small little baby, chota sa megakaryocyte, that is dwarf megakaryocyte. Dwarf megakaryocyte is seen in CML. Because CML sounds like small. If you read CML, it sounds like small. So small is going to be dwarf. Let's repeat. Staghorn, set, essential thrombocythemia, pawn ball, 3 balls hain, to therefore 1, 2, 3, MDS. Then cloud-like, I have learned primary myelofibrosis, and CML small, so that is dwarf megakaryocyte. So the mother of the platelets, the precursor of the platelets which I was talking about, that is a megakaryocyte, is sorted. Now let's talk about the platelet. Guys, what is the normal platelet count that you have to know? It is 1.5 to 4.5 lakhs per mm cube. This is just for a quick recap because this is what we'll utilize for the next 15 minutes. 1.5 to 4.5 lakhs. Now let's get going. Normal count ho gaya. Tell me the normal function. The normal function is to make a blood clot. How does platelet make a blood clot? What are the steps of clot formation? Step number 1, platelet adhesion. So imagine if this is a blood vessel in front of you, you know this is a blood vessel because you can see endothelial cells. I am saying there is an element of injury that has happened. If injury has happened, bleeding will start. Platelets will come to your rescue. So ye dekho, so many PPP platelets have come to your rescue. So how do they stop the bleeding? Please note, this is, see the way I'm saying it. Step number 1 ke liye, 1. Step number 1, that is platelet adhesion. I have GP1B9 on the platelets. That is binding to 1 Willebrand factor. Ho gaya simple. For step number 1, I have GP1B9 that is going to bind with 1 Willebrand factor. So 1 makes it step number 1. So GP1B9 on the platelets will bind to 1 Willebrand factor and platelet adhesion is done. That was step number 1. Second, the platelet is going to vomit out everything. These platelets are now going to vomit out everything. What are they going to vomit out? So the step number 2 is known as platelet secretion. Step number 2 is referred to as platelet secretion. What are they going to vomit out? So you can see over here that it has something called alpha granules. Alpha granules are going to get vomited out, and second it has delta granules. So alpha granules में देखो alpha PHA, alpha F वाला sound आ रहा है ना, alpha F वाला sound. तो all factor, lot of factors are going to come, and alpha is not actually F, it is PH wala F, है ना, P matlab the PP things are also going to be there. That is how I have learnt alpha. So alpha is all about P and F, means P-selectin, platelet factor 4, PDGF, factor 5, factor 8, fibrinogen, all factor things, and all PP things are going to be released from alpha. What is released from delta or the dense granules? Very simple. Delta or dense granules ka mnemonic is dense. Means what? So please remember, dense ko you're going to split it up. First and foremost, you consider den. Den matlab adenosine. It could be adenosine diphosphate, adenosine triphosphate, basically ADP, ATP. ठीक है? तो den. One is things den. Then with SE, I have got serotonin. SE se serotonin. Then alone you will have to take S separate, E separate. S I've called serum calcium. S for serum calcium is released and E for epinephrine is released. How nice and how convenient. Quickly let us go through it once again. When I'm talking about adenosine, so adenosine diphosphate, triphosphate, S se ho gaya serum calcium, E se ho gaya epinephrine, and together I'm going to call it SE for serotonin. Now I know what are they going to vomit out. Step number 2 is done. Now I go to step number 3. Step number 3 is platelet aggregation. Now 1 or 2 platelets nahi, lakhs and thousands of platelets are going to aggregate. How will they stick to each other? Now for the second and the third step, you have the second and the third receptor, GP2B3A. So for example, if this is a platelet and this is a platelet, this also has GP2B3A, this also has GP2B3A. Okay? This is GP2B3A, this is GP2B3A. How should I link the two GP2B3As? I will need something in between. You will say, ma'am, you need this white color pen I've got in between, that is fibrinogen. So to link them, you will have to get some fibrinogen in between them. So can I say platelet aggregation requires GP2B3A and fibrinogen to act over there. Finally, you're done. You're done with the different 3 steps of how a blood clot is formed. So, kya kara? First, you had platelet adhesion, then you had platelet secretion, and then you had platelet aggregation. All of them have aggregated and a primary hemostatic plug is formed. But that is not your final blood clot. You want the secondary plug. You want a final blood clot. How will you get the final blood clot? You will have to get the clotting system into way. So, to get the clotting system into way, you will say, ma'am, how do I activate the clotting system? Now listen to this. These platelets, ये जो primary plug बना ना, they flipped something called phosphatidylserine outside. They are gonna send phosphatidylserine outside. Phosphatidylserine is flipped, known as flipping of phosphatidylserine. And you know what phosphatidylserine has? It has a negative charge. Now a negative charge is going to develop over here. Negative charge activates the clotting system. Remember, negative charge is going to activate the clotting system, and now the secondary hemostatic plug is going to form. So repeating all of this story once again. Please note, when the platelets were doing their work, only a primary plug was formed. I was not happy with that. I said I want a proper blood clot which a clotting system can provide to me. So how do I activate the clotting system? To activate it, I need a negative charge. So I flipped phosphatidylserine. All the platelets decided we will send our PS out. PS has a negative charge. The negative charge will activate the clotting system and a proper plug will form. So now you will ask me, what is the clotting system? There is an intrinsic pathway and then there is an extrinsic pathway. This is the clotting system that I'm talking about. So because of that negative charge that you just spoke about, you know what gets activated? Now dhyan se sunna. There is 10E10. What is 10E10 that I'm going to talk about? So first factor 12 gets activated, then factor 11 gets activated, then factor 9 and 8 get activated, and they finally go and activate factor 10. 10E10. What is 10E10? 12, 11, 9 and 8 and 10. Simple. That is the intrinsic pathway which got activated by the negative charge. Extrinsic pathway matlab from outside, tissue injury. Factor 7 and factor 3 together go and activate 10. So ye bhi to 10 hua na, because I know 7 plus 3 is also 10. So everywhere this clotting pathway is about 10, 10, 10. Intrinsic pathway is about 10E10, 12, 11, 9 and 8 and 10. Simple na, 12, 11, 9 and 8, they will activate 10. Extrinsic pathway mein 7 plus 3 is also 10. So I've come to a common point, that is 10. After 10, you have to do rule of halves. Pehle you did rule of 10s. Now whatever you're going to do after that, now that becomes the common pathway. So what is rule of half? Can you tell me that what is the half of 10? Common sense. Half of 10 is 5. So factor 10 in the presence of, so now I'll write it in Roman numerals. Factor 10 in the presence of factor 5 activates factor 2. Because 10 ka half 5, 5 ka half 2.5. 2.5 to nahi ho sakta. So 2 and 2 ka half 1. So factor 2 is then going to go and activate factor 1. So can I say the common pathway is factor 10, half, 5, half, 2, half, 1, 10, 5, 2, 1, and this 10, 5, 2, 1 is nothing but your clot or nothing but fibrin. This is nothing but fibrin that has formed. And now are you happy with this clot? Nahi. You'll say, ma'am, this blood clotting system is not happy only. Pehle primary clot bana, you said, no, I'm not happy. I want clotting system. Now I've made a clot. You are still saying you're not happy. When will you be happy? One last step. I say this blood clot should be very, very stable, very, very strong. Then I will be very happy that yeah, the blood clot is formed. So for that, I require something known as factor 13. Some people like to call it fancy names like Lacky-Laurent factor. So MCQ ke liye to Lacky-Laurent factor is factor 13 sounds well, but I like practical names. What is the practical name of factor 13? Factor 13 is known as fibrin stabilizing factor. It is fibrin stabilizing factor, which means that it's going to stabilize your blood clot. It will make your blood clot very, very stable and strong. So how simple my clotting pathway is done? It was never so simple, guys. Intrinsic pathway के लिए 10 extrinsic के लिए 7 + 3 10. Once you reach a 10, you do half. 10, 5, 2, 1. Blood clot bana. Stabilize the blood clot with factor 13 and your blood clot is ready. So now you're just left with one factor which I haven't used, and that is calcium. I have learned, how do I say it? Calcium is at the connections. That is very good way of saying it. You will always remember. Calcium is at the connections. Means where are you connecting these pathways? Yahan na? This is the meeting point na. So calcium is going to be used at the connection. So calcium is used here and calcium is used here. So simple, calcium is used at connections. Hamesha yaad rahega. If you have studied all of this, you get a question over here. Which out of these were vitamin K dependent factors? Please learn it. Vitamin K dependent factors are 2, 7, 9, 10. 2, 7, 9, 10. 2, 7 plus karo 9. 2 plus 7 is 9 and 10. So 2, 7, 9, 10. These are the vitamin K dependent factors, which is a previous year question that has come in the paper. So just telling you a one-liner. Now, on the basis of this, you will ask me what are the different tests that I do, ma'am. Remember bleeding time. Bleeding time is a measure of platelets. It has nothing to do with your clotting factors 8, 9, 9. Measure of platelets. Roughly 2 to 9 minutes is the bleeding time. Okay? So when the platelet count will be a problem, platelet function will be a problem. Platelet mein problem matlab bleeding time will go up. Clotting time is roughly between 8 to 15 minutes. It's the simple definition. Clotting time. Time taken for blood clot to form. Khatam. Then we come to prothrombin time, which is 11 to 16 seconds. And please remember, prothrombin time is a measure of the extrinsic pathway. Extrinsic pathway matlab wo 7 and 3. 7 plus 3 wala extrinsic pathway. APTT 25 to 35 seconds. And this is a measure for that 10E10 pathway. 10E10 pathway matlab intrinsic pathway. 10E10 matlab 12, 11, 9, 8, all of those. 10E10 wala pathway. Finally, we have something called thrombin time. Thrombin time is going to be a measure of just one. Thrombin time is a measure of fibrinogen. Last factor measures factor 1. What is factor 1? Factor 1 is nothing but fibrinogen. So basically any fibrinogen problem happens in the body, thrombin time will increase. So first factor के लिए thrombin time था. Last factor के लिए क्या है? For factor 13, that is the Lacky-Laurent factor, we have the urea clot solubility test. For the Lacky-Laurent factor, factor 13, urea clot solubility testing. So repeating once again, इसमें confusion कहाँ आता है? Is only one place. Bleeding time, everyone learns, okay, it's to do with platelet. Clotting time is the formation of clot. Then thrombin, you have learned TT, first wala factor. TT first wala factor matlab it is fibrinogen. And urea clot solubility test, the last factor, this is also learned, factor 13. Problem occurs between PT, APTT, which is for intrinsic, which is for extrinsic. So always remember the mnemonic PET. The PT is for the extrinsic pathway. So when I come back to this, I will say for the extrinsic pathway, I am going to utilize a test called PT. And for the intrinsic pathway, I will utilize a test called APTT. So PET hamesha yaad rakhna. And do you know what is the vacutainer in which you do all this PT, APTT testing? PT, APTT testing is done in this light blue vacutainer, which is in front of you. Always remember the light blue vacutainer is important. So you've done all the normals, you've done all the timings. Now it's time for the diseases. Let's begin with the disease which is to do with whatever you studied right now. Guys, tell me, when I'm talking about the functional defects of the platelet, did I just tell you the first one wala GP1B9? Tell me, if 1B9 is defective, what are you going to call it? You are going to call it Bernard-Soulier syndrome. You shall be calling it Bernard-Soulier syndrome. GP2B3A is defective, is a disease called Glanzmann thrombasthenia. It's a disease called Glanzmann thrombasthenia. Now many students get confused in the paper that 1B के साथ Bernard था, 2 के साथ Bernard था, किसके साथ Glanzmann था? तो simple, go alphabetically. First write, first number comes first, second number comes later. B comes first, G comes later. How easy. So remember 1B9 is to do with Bernard and 2B3 is to do with Glanzmann thrombasthenia. Which out of these shows you bada platelet, big platelet? So remember B for B, Bernard-Soulier is going to show you big platelet or giant platelets. Okay, next we come to alpha granule and delta granule defect. Alpha granule में problem तो age हो गया. Age मतलब white hair. So simple, gray platelet syndrome. Gray hair, gray platelet syndrome. So remember alpha granule defect, aged. How we have learnt it, alpha, aged. Delta granule is what is left. It is known as the Hermansky-Pudlak syndrome. That is referred to as the Hermansky-Pudlak syndrome, which basically means that these patients are going to have albinism. It is a case of oculocutaneous albinism. It's a case of oculocutaneous albinism. So simple, 1B9 Bernard-Soulier, 2B3 Glanzmann thrombasthenia, alpha granule defect, gray platelet syndrome, delta granule defect, Hermansky-Pudlak syndrome. The functional defects are over for you. Coming to the next one, these were all platelet related ones. If I ask you, this is platelet ka function problem. If I ask you what is the platelet ka quantity problem, so you will say the quantity problem is immune thrombocytopenic purpura. Immune thrombocytopenic, that is telling me platelet count is going down. Immune thrombocytopenic purpura. Why is that happening? That is happening whether it is acute ITP or chronic ITP. That is immune, na? So antibody related. Antibodies are either against the GP1B9 receptor of the platelet or antibodies are against the GP2B3A receptors of the platelet. So please remember 1B9 or 2B3A, जो भी receptor होगा, but immune mechanism होगा. Some antibody will be there. So it's of two types, acute or chronic. I'll tell you the story of acute and then you guys just do opposite or chronic mil jayega. If I give you the history of a child who has the history of a viral infection and his platelet count has gone below 50,000, but within 6 months everything has come back to normal, so basically there is no treatment needed, self-limiting hai. Mainly problem kya tha? He had a viral infection, for 6 months his platelet fell and it came back to normal. Koi problem nahi, no steroids, nothing needed. If it's a history of a child with a chota sa sore throat, cold cough kind of viral infection, platelet count went down, within 6 months everything was normal, no long-term treatment needed. That is acute ITP. Versus now I call it an adult who has no such viral sore throat wala history. Platelet count is very, very low, 5-10,000, very, very low platelet count. This has been going on for more than 6 months and for this I will have to give the patient steroids. There is no self-limiting stuff that we have over here. Then I'm dealing with chronic. So I told you na, acute ITP ka chota sa bachcha with sore throat and learn that within 6 months the chota bachcha will be playing back to normal. That is acute ITP. And if you make it opposite, it becomes chronic ITP. These are immune mechanisms. This is associated with an antibody phenomenon here. These were all platelet related disorders because now I can go on to the clotting factor related disorders and we know the main ones that we are going to talk about are hemophilia, hemophilia A and hemophilia B. When you say hemophilia A sounds like 8 na, so factor 8 is deficient. So the next alphabet is B and the next number is 9. Hemophilia B becomes factor 9 deficiency. What is factor 9? Factor 9 is Christmas factor, na? So hemophilia B becomes the Christmas disease. Hemophilia B becomes the Christmas disease. So simple. When factor 8 is problem, to hemophilia A hai. And next number 9, that is factor 9 problem, hemophilia B. But tell me something, whether I say, when remember 10E10, whether I say factor 9 or I say factor 8, both of them are which pathway? Both of them are intrinsic pathway. Intrinsic pathway ke liye what is the test? The test is APTT. This means whether factor 8 is deficient or 9 is deficient, badhega kya? APTT will increase. PT is going to be normal. Only APTT shall increase, right? So now you will say that how will you treat it? How will I treat it? So basically first I will say that ma'am, how did you do the diagnosis? Dono mein to APTT came out elevated. How did you know patient has hemophilia A or hemophilia B? I'll say I'll do assays. I will find out the levels of factor 8 and I will find out the level of factor 9. Whichever will be less, I will get to know, acha, factor 8 is less, it is hemophilia A. If factor 9 is less, it is hemophilia B. Let's put logic into it. How are you going to treat it? Factor 8 de do. which is that blood product which has a lot of factor 8, that is cryoprecipitate. Cryoprecipitate is very rich in factor 8, whereas what is rich in factor 9? Fresh frozen plasma, that has a lot of factor 9. So remember, for cryoprecipitate, if you're dealing with hemophilia A because you want to give 8 factor, and fresh frozen plasma in hemophilia B because you want to give factor number 9. So I hope hemophilias are done for you. Platelet defects done, clotting defects done. The last disease that we're going to study is von Willebrand disease. Now why is this right at the end? Because I call it a combo problem. Isme little platelet problem is there, little clotting problem is there. I'll tell you how. See, von Willebrand disease is what? Von Willebrand factor है ना का problem. Normal von Willebrand factor has two functions. One function of von Willebrand factor, if you remember, was कि GP1B9 had to bind with one Willebrand factor है ना. So if one Willebrand factor is there, platelet will work well. If one Willebrand factor is not there, platelet will not work well. So can I say von Willebrand disease is going to result in number 1, a platelet defect? Everyone's understood why? Okay. You know the second function of von Willebrand factor is it is the mother of factor 8. Factor 8 matlab it's always taking care of factor 8. Factor 8 is the most useless person on this planet. Factor 8 says mujhe kaam nahi karna, I don't want to work. If von Willebrand factor will be with me, then I will work, otherwise I will not work. So von Willebrand factor is a carrier of factor 8, like a mother, it's carrying it everywhere. So when von Willebrand factor was there, factor 8 was working. Now when I say von Willebrand factor is not there, factor 8 will not work. So can I say in von Willebrand disease there is a factor 8 defect also? Ultimately I realize that in the von Willebrand disease there is a platelet problem and a clotting factor problem. So if platelet is a defective problem, what is the time that will increase? Bleeding time will increase. Platelet ke liye bleeding time. And if I say that factor 8 has had a defect, you'll say factor 8. Factor 8 was intrinsic pathway. Intrinsic pathway means APTT. So these patients are gonna present with elevated bleeding time. PT पे कोई effect नहीं है and elevated APTT. That is the profile that you get in a patient of von Willebrand disease. Very important. You've understood why. Because there is a platelet problem, bleeding time increases. Because there is a factor 8 problem, APTT is going to increase. And that is how you define von Willebrand disease over here. There are many types of it which I've explained to you in the main syllabus. 1, 2, 3, 2A, 2B, 2M, 2N, lots of details. But those are like in nitty-gritty details. These are the main things that you have to focus on. So jaldi se if I ask you something, if I mention these things, Bernard-Soulier and Glanzmann thrombasthenia, what are they? They are problems of platelet na, to kya badhega? If they are problems of platelets, what will increase? Bleeding time will increase. Okay. Similarly, ITP. ITP was also a platelet problem. The platelet count is over here. The platelet count is going down, but ultimately bleeding time will increase. So the only difference is that in these, the platelet count was not going down. These were both functional problems. These were both functional problems. So the platelet count was remaining normal, but platelet mein to problem hai na, so the bleeding time went up. ITP maybe the bleeding time is going up, but this time because the platelet count is going down. Talking about hemophilia A and hemophilia B, factor 8 deficiency and 9 deficiency, since both of them are associated with what? Both of them are associated with intrinsic pathway. What is increasing in them? APTT is increasing in them. Now I can add to the list von Willebrand disease, in which there was a platelet problem also, so bleeding time will increase. There is a factor 8 problem also, so APTT will also increase. Everything else shall remain normal. So that becomes your most important summary list in the end that you are gonna refer to. And on that note, the quickest summary possible of platelet and clotting factor disorders comes to an end.